very heavy rain.
Yes.
So ma'am is having difficulty to get connected.
Okay.
So I just requested that I would request to chairperson to handle meanwhile, and she will join in between.
No problem. No problem. Yeah.
So Justin, are you with us? I'm just looking for third presenter.
Sure, sure. No worries. Once when it is ready, we will.
Justin, please raise your hand if you have joined with some other name, because I could not see your name over here. So I was just briefing you, sir. We have three papers in this session,
Yes.
and that preliminary part is over. Now it is up to you and the Satabdi to evaluate their presentation. As per earlier guidelines, we have sent them the previous messages. We send information that they will get 15 minutes for the presentation.
Yes.
And 5 minutes for the discussion.
Yeah.
But due to this means I am almost 11-minute delay. So it is up to you and Dr. Satabdi now that what you decide, whether you want to reduce their time or you want to allow them at the
We
same
will
time.
make it 10 minutes, 12 minutes, 12 minutes we'll make it.
Okay, all right. So, sir, we have two presenters, and that Dr. Satabdi is having some difficulty.
Okay.
So she would be joining in between.
Fine. If only two presenters are there, we can continue with 15 minutes. It's not a problem. Because
she has joined. She is here. But the third presenter is not there. So
we will start off with the first presenter. She has,
I think
Sadapti has joined.
Yes, she is here.
Yeah, yeah. Good afternoon, Sadapti.
Okay, so good afternoon, everyone. So we are starting our second day award paper.
Yeah.
For the professional social work practitioner category, we have two chairpersons with us. First, Dr. E. Arvind Raj, additional professor in the Department of Psychiatric Social Work at NIMHANS, Bangalore, and president of APSW, and a very good academician, having an n number of publications and n number of research work in his credit. And that another chairperson for today is Dr. Satabdi Chakravarti, another additional professor in the Department of Psychiatric Social Work at ISPSW, Delhi. So, sir and ma'am, welcome to both of you in this session. And yes, we have three presentations in this category. First, as per our list, first is Asa Malik. Second is Miss Asa. Sorry, it is not, although it is visible as Malik in our presentation. Then second is Justin Raj, and third is Mr. Chetan Sharma. So over to you with all these three papers, and I'm here at your service. Please let me know if I can assist in anywhere. Over to both the chairpersons.
Okay. Welcome all the presenters for today's award category presentation. As Dr. Bhupendra was saying, you would be given 15 minutes of time. Sorry, all three are present there, right? Bhupendra? All three are there, right?
Yes, all three are there.
So then we will fix it as 12 minutes because we are already 15 minutes delay.
Sir, actually, you have 1 hour to finish the session.
Okay, fine. Then
you have 46 minutes from now. So
okay,
it is up to you.
So we will make it as 15 minutes, no problem. We will anyway shoot up little 10 minutes or so. That we will keep it that way as given for them, so that they would have been prepared that way. Then we can ask if anything from Shadapti, please. Shadapti? All right, I think, yes.
Yes, yes.
Yes.
Actually, due to weather, I am facing some network issue.
No problem.
We can start.
Yes, yes,
And
yes.
if in between, if I log out, then you will understand that there is some
Got it,
network
got it.
issue. When there is
Yeah,
a heavy
yeah.
rain is going on.
Sure,
So,
sure,
yeah.
sure. No worries. So first, as per the order, can we ask Miss Asha and the team to you know give her presentation about their study on of psychosocial interventions in schizophrenia, effectiveness and challenges. Yeah, please go ahead.
Asha, please go ahead.
Yes. Yeah, you can start your presentation, Asha. You are not audible. Asha, you are not.
Asha, please check your network. We can't hear from you.
Semi audible?
Yes, now you are.
Okay, sir.
You can start. Your time starts now. No, again we lost the volume.
Is it started?
No, that's what. Now she's trying to. Yes.
Sir,
Yeah.
can I
Yes, please
present
start.
things in
Please.
start?
Yes, start the presentation.
Good morning to all of you, and thanks, Dr. Bhupendra sir and the chairperson. My name is Asha. Presently, I am working in a private psychiatric hospital as a psychiatric social work in Haryana. Now, I'm going to present a case study of the psychosocial intervention in the schizophrenia, effectiveness, and the challenges.
Mhm.
Schizophrenia is a serious mental illness
Mhm.
that affects how a person thinks, feels, and behave. People with schizophrenia may seem like they have lost touch with reality, which can be distressing for them and their family and the friends. The psychosocial functioning, including social activity, personal, social relationship, and self-care, is a key issue of schizophrenia and ultimate goal for managing schizophrenia. A study from Italy that explored the relationship between the negative symptoms and the functioning found that the adolescence was strongest predictor of overall functioning, socially useful activity, personal and the social relationship, and the self-care. This line of evidence may suggested that the such psychological functioning may have a correlation with the psychotic symptoms as well as the several additional factors undergoing or using the preventive and therapeutic interventions concurrently targeting personal, family, and environmental factor may be path to improve the functional outcomes. Objective of the study: the role and efficacy of psychosocial intervention in non-pharmacological management of a patient diagnosed with schizophrenia having psychosocial issues. Material methods of the study: a single subjected case study design was employed, conducting pre and post intervention assessment. For assessment, the family burden interview schedule developed by Pai and Kapoor 1981 and the positive negative syndrome scale PANSS developed by K et al. Were administered both before and after intervention. The psychiatric social work interventions was carried out with the patient and the family, included psychoeducation, social skill training, supportive psychotherapy, addressing the expressed emotions, enhancing the support system, and supportive work with family. Case description: Mrs. A, 30 years old female, studied up to 11th standard, married, unemployed, belonging to a Hindu nuclear family of upper socioeconomic status of Bihar. The patient was maintaining well until November 2019. After 4 months of the marriage, she quarreled with family members and unknown and would get irritable and aggressive over tribal issues. She did not engage in any household chores when asked, she would get irritable and would answer in appropriate language. If her mother-in-law tried to teach cooking, she would not cooperate and would use to stay in her room alone. She would often threaten to leave home if her demands were not fulfilled. After some time, patient's husband started living separately with the patient. Sometimes her husband was noticed that when she was all alone in the house and doing some work in the kitchen, then also answering to hear some voices. And after asking by the husband, she was silent and sometimes continued to answering that voices. Her husband reassured her that there was nothing like this. In the year 20, after that, in the year 2020, when the patient was 5 months pregnant, husbands reported that her irritability increased and she hit herself in head and her belly in range without any issue. She was taken to a private psychiatrist on the advice of a neighbor, but after some times treatment was stopped. After that, the patient's husband observed that she would not take care of her newborn baby and would not feed her regularly. She had a careless attitude towards her. Sometimes she beats her baby. Then, after this repeated behavior, patient's husband took her to multiple faith healers, and sometimes he kept her in a closed room. Sometimes her use critical comments also. She came to PJMS psychiatric department with the complaints of irritable and aggressive, decreased social interaction, agitation, suspiciousness, hearing of unusual voices, disorganized behavior, decreased sleep, and occupational functioning deteriorated severely. The patient was disorganized with the diagnosed with the schizophrenia according to ICD-10. Reasons for the psychiatric social work intervention. Although the treatment of the schizophrenia is dependent on the medication, but along with the psychosocial intervention play an important role as the helping hand in improvement. Psychosocial assessment and the interventions for awareness about the mental illness, impact of the mental illness on family issues due to the illness, evaluation and planning of rehabilitation, psychosocial issues, poor knowledge of the illness and the poor compliance to treatment of patient, poor communication pattern with family members, caregiver burden, poor role performance, expressed emotions towards patient, psychosocial intervention and the goals to establish the rapport with the patient and her family, to address expressed emotions, to address the caregiver burden, psychoeducation, supportive psychotherapy, active scheduling of the patient, social skill training, pre-discharge counseling. The psychosocial intervention was implemented in form of psychoeducation, like explain about the nature, cause, and importance of the regular treatment, activity scheduling, and social skill training for the patient to improve the daily living functioning and able to express positive feelings and unpleasant feeling, supportive sessions for the ventilate the pent up emotions to build up hope and the motivation, active listening and the emotional support, psychoeducation session with patient and the family members. In the result part of the study, the table shows the family burden. In the post-intervention assessment, there was a reduction in the domains of family burden after interventions. This slide shows about the positive and negative symptoms. The blue column for the pre-intervention assessment, which was reduced after intervention, like significant improvement was observed and analyzed, which indicate improvement in the patient symptoms, social skill, activities of the daily living, and attitude of the family members towards the illness of and patient. Outcomes of the study on the individual level, the patient showed improvement in the symptoms, communications, daily living, interpersonal relations after active psychosocial intervention. She also had the better understanding of illness. On the family level, the level of expressed emotions was reduced after psychoeducation and supportive psychotherapy, and the caregiver burden was also reduced after the involvement of in-laws. Their understanding of the illness was also enhanced. Challenges faced during the treatment. It was challenging to contact the in-laws of the patient, to psychoeducate them about the patient illness, had difficulties to make an understanding among the family members because the family environment becomes disorganized with disagreement, frequent argument, and high noisy level. Had difficulties in addressing the faith healing beliefs of the patient's husband. Discussion and the conclusion. Chronic disease like schizophrenia have a severe impact on the patient, on their families. The present case study shows that the psychiatric social work intervention cover the different area of the illness and could be effective in dealing with issue like the family burden, poor social skill, enhancing the well-being of the patient as well as their family, and improve the socio-occupational functioning. The tailored psychiatric social work intervention program in the treatment of the family as well as the patient was found to be effective and needs to be integrated into the routine practice. In the conclusion part, there are like some reduce the family burdens and reduce the myths and misconceptions of the family members, increase the understanding of the illness, and can provide the future directions for the practitioner to deal with such kind of issues. These are the references. Thank you.
Thank you for keeping up the time. And we have a few questions to you. Just to talk about the intervention, what is the overall the theoretical framework you thought of when you are talking about the intervention for both individual and the family members?
Theoretical framework like psychoeducation for the family members, like
Yeah, those are all interventions, right?
activity scheduling of the patient
Mm-hmm.
and social skill training of the patient
Yeah,
and
these
understanding
are
of
all interventions. I totally understand. I agree with you. But to decide all these things, no, some theoretical framework in terms of approach for the interventions. What are the approaches? How can you put all these things in under one? You spoke about expressed emotions and all these things, and you also dealt with family. Any approach you can remember with regard to family related things?
um individual psychoeducation and family psychoeducations.
Okay. Again, you are only talking about various interventions what you had given, therapies. Under what background these therapies are designed. See, for example, if you think of systemic approach, family systems theory, all these things will come under that, isn't it? In terms of educating the family members about expressed emotion, because their thing will have an excuse me, their thing will have an impact on the patient's behavior. So that is what exactly the systems theory talks about. So that is what I was asking. That's okay, doesn't matter. And what is the limitation of your study?
In limitations part, when the theoretical framework along with the treatment using
Mm.
continuously then working, if the patients left from both the treatment, that is the lacking part of the limitations of these all kinds of therapeutic approach.
No, no, I am talking about limitation of your study, what you have presented. Of course, you spoke about the challenges that way. In this, whatever you are presenting it, what is the limitation of your study findings? You spoke
Uh,
about there is an increase in or a decrease in positive and negative symptoms, increase in functioning. These are all the things what you spoke about. Can you think of just having one case study method in that using quantitative measurement tool, though it has come as a positive outcome, can we generalize it? Can it be a limitation?
Sir, yes, the
What?
only one case, not the
Mm,
generalized, and
mm,
it's
mm.
big limitations for the
Yes,
research.
yes, yes, yes.
Agree, sir.
And what could have been the alternative way of measuring the outcome?
Sir, what? Sir, I'm not
What
to
could be the alternative way of measuring the outcome of your intervention using single case design?
outcomes of if it can
Huh.
be provide future direction to a particular case to for the practitioner such kind of issues and challenges we can use of this kind of um,
Okay.
practices to deal with
Okay.
cases.
All right. All right. Fine. All right. That's it from my side. Shadapti?
Yes.
Yes, your question.
So what are the approaches you have used for individual psychotherapy?
Yes, ma'am. Hello.
What are the approaches you have used for individual psychotherapy, or what are the domains you have focused on individual psychotherapy? Am I audible?
Yes, ma'am.
If you are not clear or if you are not knowing the answer, you can just tell us so that we can move on to the next. Asha?
Yes, sir.
Yeah.
For the individual psychotherapy, the educate to the individual level, patient's husband and the family level, family members of the patient.
Then how come it is different from individual psychoeducation and family psychoeducation? You have mentioned both.
Individual psychoeducation, ma'am, included the patient and the patient's husband and family members comes their in-laws.
What are the areas you focused in your individual psychotherapy session?
Ma'am, both individuals, a patient, family, and their in-laws. Because patient need the support their in-laws family also.
You are not getting my question. Okay, it's done from my side.
Okay.
We can go for next.
Yeah. Thank you. Thank you, Shadabdi. Thank you, Asha. Now we will request Mr. Justin Raj. Hi, Justin. Yeah,
Yes,
I
sir.
think you can.
Can you hear me, sir?
I can. You're audible. You can go ahead with your presentation.
Yes, sir. Thank you.
Your time starts now. Yeah.
Hi, good
Yeah.
afternoon, all. Myself, Justin Das PC. I'm the first and present year author of the study titled Exploring the Impact of Online Learning over Conventional Learning on the Professional Development of Social work Students across India in the post-pandemic era. So there are for this Professor Nishant Goyal, Dr. Narendra Kumar Singh, and Dr. Umesh. So this study was conducted in various states, social work institutes, and presented this topic for the award category of social work practices. So here the starting with the introduction that Fossey et al. Had a study on conventional to online education during COVID pandemic due to development and underdeveloped nations coping right. So he described that online learning is being carried out to avoid face-to-face contact in emergency scenarios such as coronavirus infectious disease 2019 pandemic. The adoption of online learning strategy has reportedly improved learning efficiency and performance. So then there was other study, Clark et al. They have given uh, global higher education institutions are increasingly integrating e-learning service into their systems. serving as an alternative or supplement to traditional learning. There's another study that Kossi et al. The other study of it is that students are required to adopt to new learning tools through information technology to achieve academic success during COVID-19. So they formed done a study and he described that the lockdown has had a significant impact on students, prompting a shift from traditional teaching to online learning resources. So when it comes to the negative side of the online learning, CAPSIA given a good understanding about that. Most of the learners were used Android mobile phone for attending e-learning. Students have been facing various problems related to depression, poor internet connectivity, and favorable study environment at home. Students from remote areas and marginalized sections mainly face enormous challenges from the study during this pandemic. Mostly, this is a study done in India. The rest of the studies are done in foreign countries. So there is certain, and George has given a study on that. He says that they have described that a feature that suits disruptive and immediate transformation for higher education curricula is described to serve global universities from the ravages of the stay-at-home policies. The move to a totally online environment took place overnight, and most institutions of higher education were totally unprepared. Yet a future of possibility could be adopted in the coming 5 years. One in a particular, one in particular being game-based learning and andragogy based upon experimental education. So there is other study on social work education. In social work education, the interplay between academic and practical learning is crucial. This involves socialization within the academic and professional social work community, exposure to complex real-world social practices, and reflection on the intersection of scientific knowledge, practice knowledge, and the service user perspective. And same study also described that adapting teaching and learning method present didactic challenges. Research indicates that when undergraduate social work students feel recognized by instructors and peers, their motivation to learn and engage with course material increases. So the research question of the study is that to find impacts of online learning over conventional learning for social work students in various states of India in the post uh, COVID pandemic era. So it's a conventional learning to online learning, how it's adopted. And come to the methodology part. The Institute Ethics Committee has approved the study. An online survey study design was used for the study. Online informed consent was taken from the subjects. Data collection from various social work institute across India through online using Google Form, and statistical analysis also done at CAP Ranchi using IBM 29 and Python 3. So subjects inclusion and exclusion criteria were students who were completed Master of Social Work course during COVID pandemic 2019 and 2021 sessions. And while rest of the pre and post pandemic area were excluded from the study, regular MSW students, course students were included in study, and while the distance and part-time MSW students were excluded, and students who were accepted online consent form were included in study. So I have used materials like social demography profile, and the second one is modified self-assessment questionnaire for online education and conventional learning. The questionnaire consists of 35 items, was designed as a Likert scale. Response has given 1 to 5. And their subdomains are practical learning, theoretical learning, adaptation of new learning technology, and outcome of online learning. And the scale adopted from the study of Debrahma and Durai 2021. And the data analysis were done descriptive statistics and frequency distribution to understand prevalence. And skew test was used to understand the normality of the data and normally distributed on dependent variables. So we have used ANOVA to compare the various students, various statistics. And we used IBM 29 SPSS for statistical analysis and Python 3 for data visualization. So study procedure, here is study procedure. Master of Social Work students from various institutes across India, and 22 institutes we were approached and from across the 12 states representative. And online survey details shared to, and there was 370 subjects where we have approached, and online survey data were shared to this 370 subjects, and 390 people participated in study, and the rest of the participants were excluded. And social demography, after agreeing the consent, giving the consent, social demography profile and modified self-assessment question were completed by the subjects, and then the data analysis was done. So here the results. Among this all 390 participants, gender, the female subjects were high with 69% of the percentage, and 39% of the male participated. And the many people are responded that during COVID season, it was so expensive because of the gadgets they were used for the attending the online classes. And gadgets mostly they have used mobile phone with the facility of online learning applications. And interestingly, there was a question that on fear of COVID, and there was mostly 58% of the participants given as they have fear to COVID. So next to come to the state-wise representation. So here West Bengal and Kolkata, they were scored high in the representation for the data. And Jharkhand, well, in Jharkhand, I have approached only Ranchi, so there was only Central University, so we have got less number of people. So state-wise, the screen time and duration of classes, both are in hours. So there are high frequency has seen in West Bengal as well as Kerala. They using screen time and same. It's high screen time lead to high, the duration of class time also is high. So when it comes to low frequency, Jharkhand as well as Telangana, where less number, they are having less participants. They have used less time in screen time as well as they have used less time for the class. So state-wise difference in online education and conventional education, the domains are described earlier. So all domains are given, like adoption of new learning technologies, theoretical learning, practical learning, and online learning. All were given the high, more adaptive in West Bengal than the other states. So when it comes to adoption of new learning technology domain, Karnataka was less adaptive in the speed of adapting the new technology. And when it comes to theoretical learning, so mostly Kerala and UP people are more towards the theoretical learning than the online learning. So when it comes to practical end, Telangana was they were taking more time to adapt to the online education system. And when it comes to online learning, there are three states: Andhra Pradesh, Madhya Pradesh, and Tamil Nadu, were having less adaptive to online learning, and they are in slow process. So when seeing the significant differences, the all the domains are having very high significance with a p-value of less than 0.001 level and with a high value of M score and over. So when it comes to discussion parts, in the context of social work education, this transition has been particularly challenging due to the practical and field-oriented nature of the discipline. So there is a study by Santos. He's given a good description. Participants adopted well to new technology, learning technology, indicating flexibility and accessibility offered by online platform. However, the study also revealed decline practical learning without descriptive. So the other study is given, they highlighted the need for comprehensive strategies that address not only the technological requirement of online learning, but also the socio-economic and psychological factors that influence students' learning experience. So the other study given the same findings as ours, our study findings aligned with the previous research indicating that effective of online and conventional education can vary significantly depending on various factors, including the availability of resources and the level of teacher training and the socio-economic background of the student. And in conclusion, the present study reveals that pandemic necessitates a rapid shift to online learning, challenging social work educators and students alike. While online learning offers flexibility and accessibility, maintain the integrity of practical learning remains crucial by addressing challenges and implementing effective strategies. Social work education can continue to thrive in the digital era. There are some recommendations and directions. So there are infrastructure development, pedagogical strategies, research and evaluation. Where long-term study could be have done to understand the effect of online learning in the social practices. So I am acknowledging that Central Institute of Psychiatry to support my study and the authors, the rest of the co-authors given the comment and suggestions as well. And the ethical clearance was taken from the ethical committee of the institute, and there's no funding has been given for the study. Thank you.
Thank you, Justin, for keeping up the time. Exact 15 minutes you have taken. And some of the questions I have regarding the research design and the sampling technique. What is your research design and what is the sampling technique?
Survey method is used for the study, and the purpose is sampling has been used because I have taken from only
survey
the
method is the research design.
It's
That
a
right?
survey method.
That is the research design, or is it a sampling technique?
Design is purpose is sampling.
Sampling design is what? Sampling technique? What is the sampling technique you used?
Sampling technique is survey method.
Okay. What is the research design?
Online survey method.
What is the research design?
Design is
research design, not sampling design. Research design.
Purpose is sampling because I have taken only the single group, the target group for the study.
No, Justin, I am talking about the research design. in the sense whether it is descriptive or exploratory. What is it?
Given the descriptive statistics, so it's a
Yeah, so
descriptive.
why research design? Why I'm asking you the question is your title says exploring the impact. That itself, it's more like an exploratory. Exploratory is something, the thing which has not been done. So you're just exploring with qualitative aspects. But in your review
Yeah,
of literature only, you had mentioned about many studies which has been done in this particular area. And your discussion also, you are able to compare it with the previous. So probably it can be just the impact of online learning and
yeah.
across India, that could have been the right topic. And what could be the reason for the difference in the region-wise distribution of whatever the results you said, no? Adaptability and all. What could be the reasons?
It can be the accessibility of the
Hmm.
network. There is
Yes.
a reason for accessibility of
Okay.
network.
Okay.
And there is the learning towards the new technology, where most of the people were not known to the
Hmm.
Zoom and the
Hmm.
WebEx. There
Hmm.
are so
Hmm.
many
Hmm.
like
Okay. Okay.
learning platforms,
Okay.
and there are even the students were like they were not interested in like
Hmm.
sitting in
Hmm.
front of screen and learning so much
Yeah.
of time.
Yeah.
That was the most I got the reply from the participants that
Okay.
have given.
Okay. Okay. And last question, what is the validity of the questionnaire what you used?
That
Is it?
actually they have not, I have taken this adaptation from them. They have not, with the permission of the author, but they have not validated the thing. They
Hmm.
have published it in article, but they have not validated. That's why I have not mentioned validation and reliability.
No, as part of your study, if not for this presentation, you have enough number of
Actually, I
samples.
have not done the validation.
No, you can do it. You have that.
Yeah,
You
yeah, I
can
can
do
do.
the
For
reliability
further
scores and
paper,
everything.
yeah, for research article,
Okay.
like
Okay. All right.
sure.
Then.
That's why I have taken 390 data because I
Yeah.
need
Yeah.
1:5. That's why.
Yeah. Okay. Thank you. Shadapti, over to you. Is she there?
Justin, is it your study or is it a part of any program?
No, no, ma'am. It's my own study. I have presented. That's
And
why I
you
have
have
not
done.
resident. Yeah, yeah.
What is the procedure you have taken from to obtain the consent?
Ma'am, we have created a Google. This before the Google form, we have created a. In the Google form, we have the. So for the procedure, they have to click yes or no. Then only they can go for the this one, assessment. Otherwise, they can withdraw from it.
Okay. Thank you.
It is taken online, purely online.
Okay. That's it from you, Shadapti?
Yes, yes.
All right. Fine. Thank you, Justin.
Thank
Yeah.
you, sir.
Now
Thank
we'll invite the third presenter, Mr. Chetan Sharma. Study on caregiver stigma and quality of life in patients with schizophrenia. Please.
Good afternoon, sir.
Chetan, your
Good
both
afternoon,
the
ma'am.
slides are seen, Chetan.
Sorry, sir.
Your both the slides are seen. That
Okay.
you can
Waiting.
you can make it as a normal presentation mode. Yeah, you now go for Yes, this is fine.
It
You
is okay
can,
now, sir?
yes, you can
Okay.
start now.
Thank you, sir. Sir, thanks for this opportunity for presenting me in award paper category. Sir, I am Chetan Sharma and currently working as a psychiatric social work in Naman project at AIMS Rishikesh. And the author of this study was Dr. Preeti Singh, Senior Professor, Department of Psychiatry, Pandit B.D. Sharma, University of Health Sciences, Rohtak. The title of my study is Caregiver Stigma and Quality of Life in Patients with Schizophrenia, an exploratory study. So, starting from the background of the study, as we know that schizophrenia is a chronic disease that impacts different aspects of patients and their caregivers' lives. The global prevalence of schizophrenia is 0.32%, as a study conducted by Ibrahim et al. In 2020. In India, findings from the National Mental Health Survey 2015-16 indicate that common mental disorders affect approximately 5.1% of the population, with a lifetime prevalence of schizophrenia estimated at 1.41%. In countries like India, access to rehabilitation services for individuals with mental illness is scarce. Consequently, the primary source of caregiving typically comes from informal support provided by family members. Family members frequently play a pivotal role in decision making regarding treatment seeking and various related matters such as accompanying the patient during hospitalization, monitoring medication intake, assisting with daily activities, addressing basic needs, and determining the continuation or cessation of treatment. It is commonly observed that factors like stigma, which caregivers may perceive, could potentially influence the aforementioned areas. The pervasive discrimination and stigma associated with mental illnesses are quite prevalent. Stigma affects self-esteem for both patients and the caregivers, which can strain their relationship as well. Several studies conducted in India indicate that family members of individuals with severe mental disorder encounter significant stigma and experience a reduced quality of life due to their association with a person with a mental disorder. Given these factors, the quality of life of individuals with schizophrenia can be significantly impacted. Unfortunately, there is a scarcity of studies from India that have examined the influence of caregiver stigma on the quality of life of patients with schizophrenia. So, keeping this in mind, this study aimed to investigate the stigma experienced by caregivers and its effect on the quality of life of individuals with schizophrenia. So, coming to the methodology, the study design, this is a cross-sectional study, was conducted at the outpatient department of psychiatry of Pandit B.D. Sharma University of Health Sciences. And the study sample include 160 patients diagnosed with schizophrenia according to ICD-10 by the treating psychiatrist and their respective caregivers. If we talk about the sampling technique, the purposive sampling technique was used. And for that, we have the inclusion criteria, which involves the individuals diagnosed with schizophrenia as per ICD-10, currently in remission, aged between 18 to 50 years, any gender, able to read, write, and understand Hindi language. And for the caregivers, we have inclusion criteria that range the age between 18 to 60 years of any gender who could read, write, and understand Hindi language. And the exclusion criteria for these participants were the individuals with organic brain syndrome, mental retardation, comorbid psychiatric and physical illnesses, comorbid drug dependence. And for the caregivers, the inclusion criteria includes the acute physical or mental illness or substance use. Let's talk about the study tools and analysis. Patients and their caregivers were evaluated using the following tools, like the self-designed social demographic proforma, the Jaipur stigma questionnaire, which used to assess the stigma level of the caregivers, the Hindi version of this, and the WHO quality of life ref version, Hindi version of this tool was also used. And if we talk about the analysis, the study analysis was carried out using IBM SPSS trial version 20. Now coming to the results, the social demographic profile of the patient shows that most of the patients belong to the age group of 26 to 35 years and belong to the were males. And the majority of the participants were unmarried, belong to Hindu religion of nuclear family and living in a rural locality, and 65% of them were unemployed. And if we can see that most of the patients were educated only till the secondary level. And if you talk about the age of onset, in this study, the majority of the participants, that is 59.4%, was the age of onset of these was between 15 to 25 years, with the total duration of illness 6 to 10 years. And 60% of the patients were on the treatment for the last 2 to 4 years. And if you talk about the quality of life of patients with schizophrenia, the mean score of the quality of life of patients with schizophrenia was 11.35% in the physical domain, and in psychological domain it is 9.32%. And if you talk about the overall health, or can say general health, that is falls within the category of 2.65%. This shows a low level of quality of life. Social demographic profile of caregivers. The majority of the caregivers belong to the age of 26 to 35 and 56 to 65. That is respectively 30% for the both. And 57% were male, belong to the Hindu religion. And 90% of them were married. And the maximum number of caregivers were educated till secondary class. Now coming to the stigma experienced by caregivers of patients with schizophrenia. This is the Jaipur Stigma Questionnaire interpretation, and it has 14 domains like social distance, rejection, hereditary, etc., and which can be categorized into 4, like no impact, stereotyping, prejudice, and possible discrimination. So if you talk about the social discrimination, 42.5% of the participants reported prejudice in that area, that they are feeling some kind of prejudice in the society. And 90% of the patient believes, caregivers believes that presentation in media of the person with mental illness is not appropriate, and that is related to some kind of prejudice. And similarly, in 47.5% of participants believe chronicity of illness falls in the category of prejudice, and 70% of the participants reported prejudice in the area of domain of marriage, and 87.5% falls in the category of stereotyping and discrimination also. Now, coming to the relationship between stigma faced by caregivers and quality of life of patients with schizophrenia. This table reveals that the social distance domain of stigma was significantly negatively correlated with the psychological, physical, and environmental quality of life. And heredity was also negatively correlated with the psychological and social domain of the quality of life. And marriage also related with the physical and psychological quality of life, and also the environmental quality of life. So this is the finding from the relationship between the caregiver stigma and quality of life of patients. As we have earlier seen this. Now coming to the discussion. The levels of stigma in the facade of caregivers are tested for the correlation with multiple quality of life aspects. In patients depicted a significant correlation. Social demographic characteristics of both patients and caregivers should be acknowledged, as they may impact stigma perceptions and experience and overall quality of life. Accordingly, patients in the current study were mainly in the age group of 26 to 35 years, male, unmarried, from rural background, and unemployed. These demographic profiles offer a broader scope to evaluate how societal norms and cultural beliefs surrounding the stigma experienced by the caregivers correlate and in turn affect the patient's quality of life. As detailed in the results above, stigma experienced by the caregivers covers multiple domains. These domains depict the complex nature of stigma, encircling mental illness and its impact on the individuals living with this condition and their caregivers. Similar findings were observed in the study conducted by Manisha. Findings also indicated a negative association between multiple stigma factors, including marriage, coercive treatment, and shame for consultation, with the physical and psychological dimension of the quality of life. This result demonstrates how society's overall perceptions and predisposition can significantly affect the well-being of people with schizophrenia. Last but not least, the correlation between stigma and quality of life demonstrates an existing link between social perceptions, self-esteem, and mental health outcomes. The findings also shed light on the required targeted intervention aimed at reducing stigma in caregivers and improving the quality of life of patients diagnosed with schizophrenia. To summarize, stigma can be reduced and well-being of those affected by schizophrenia can be improved by addressing misconception, promoting empathy, and creating a supportive environment. These might include educational programs, community activities and events, and psychological support for caregivers and patients. And despite our best effort, we cannot ignore certain limitations of our study, which include cross-sectional study design and self-reporting questionnaires that can include biasness also. And so the future directions, future studies may consider using longitudinal designs and more objective measures to deepen the knowledge of the caregiver stigma, patient quality of life relationship. Furthermore, studying the effectiveness of stigma reduction treatment in practice may provide useful information to guide evidence-based practice decision on the support for people affected by schizophrenia and their caregivers. Now, concluding this, this study contributes to the growing body of literature on caregiver stigma and its implication in the quality of life of patients with schizophrenia, identifying specific domains of stigma that impact patient outcome provides a foundation for targeted intervention to address stigma and improve overall well-being in this vulnerable population. There is no conflict of interest between the authors. And the ethical approval and consent to participate, the ethical clearance was taken from the Institutional Ethical Committee, and the written informed consent was obtained from the study participant themselves before the interview. For illiterates, the written consent was signed in the presence of a witness, and if privacy and confidentiality was maintained. Now, acknowledgement. The authors acknowledge the immense help received from the scholars whose articles are cited and included in the reference of this manuscript. The authors also would like to thank all the respondents included in the study for providing their valuable time and making this study possible. These are the references, and these are the tools. Thank you. Thank you, sir.
Yes, thank you, Chetan. Thank you for finishing it on time. Some of the questions from my side. What are the other confounding factors from patient side which could have affected their quality of life? Your study, yes, I know it is between the stigma experienced by the caregiver and the quality of life of the patient. But what are the other confounding factors which might have a impact on a patient's quality of life other than caregiver stigma?
Sir, if we talk about the patient's caregiver, quality of life, it can be affected by the total duration of illness they have and the environment they are living in, and like the nature of employment, if they are employed or not, and the relationship between the caregivers and the patient, like the supportive environment from the family members. So these all things affect the patient's quality of life also.
So that part, where did you consciously leave it, or what is the reason for not including those aspects?
Sir, I consciously left this part for this particular study, and in future, we will plan to involve some kind of study like interventional study or else.
Okay. And what is the gap between the onset of the illness and the treatment of the patients, the average, the gap? Because you spoke about onset as well as you spoke about treatment. We just want to know that average gap.
Sir, basically in this study, we haven't analyzed that, and we didn't include that also. But if we talk about the National Mental Health Survey 2015-16, that is nearly about, if I remember that, it is like 85% for total mental illness. If I'm not wrong, sir, but that is not
treatment gap. That is treatment gap.
Yes.
But with regard to the persons who are getting treatment, I am talking about that 15% who have come for the treatment, the duration between the onset of their illness and then the time they sought treatment, because that will be one of the important variable in general will affect the quality of life, right?
Yes, sir.
Yeah, so that also you can incorporate.
Yes, sir. If I talk about my general observation during this study, most of the patients come after like 6 to 7 months or after 1 or 2 years after getting bonding here and there with the quacks or like
Okay.
Baba, around all these things after that.
Okay. 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 Fine. All right. Thank you. I think there are no more questions from Shadapti because she has communicated to me. So we would be concluding it by thanking all the presenters for taking time to present in this association conference. Thank you all, and thank you organizers for giving me the opportunity. We will be letting you know the results after consulting with the conference organizers. Thank you very much. Thank you, Dr. Bhupendra.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you, Arvind sir,
Thank you. Thank you,
for
Bhupendra.
being available to
Yeah.
us
Yes.
and chairing this session.
Yeah.
Thank you, Satabdi ma'am, for managing despite that difficult network and that
Yeah.
heavy rain in Delhi. Thank you, both the chairpersons. Thank
Yes.
you, all the presenters, for being with us in this session and all. Thank you so much. One and all, we would be having our. Yes, sir. You want to say something?
Oh, just
Arvind sir?
about the marks, how do I send it?
That you have to send me personally, whether on
I'll,
WhatsApp or on
I'll
email.
send the
It is
Word
up to you.
document based on what
Yes.
I have assessed, and I can
Yes.
send it to you. Huh? Okay. Okay. Thank you. Yeah. Thank you. I'll leave
Thank
this.
you all. So we are going to have our next session over here. That is on means that is a symposia, and we have three experts from CIP itself, and the two chairpersons from two different premier institutes. Just allow me a second to. So for the presentees, means today's experts, I can see only one. May I request others to raise their hand so that I can find them?
Good afternoon, sir.
Hello, Ataullah. Yes, I was able to see you and I added you.
Yes, sir.
Ritika, no, not Ritika. I'm talking about the attendee presenters for this symposium session.
Yes, sir. So Khushbu, me and Megha is here. We are just connecting ourselves through other devices. Actually, we are planning to present the whole symposium from one place onwards.
Okay, okay.
Yeah.
That's
So
right. That's fine.
yes, sir.
I
So we
thought that
just yes,
I
sir.
have to find three different devices.
Okay.
That's why I was looking to that
No
for
issues, sir.
different places.
So
and all.
we just need 2-3 minutes to set up all these things. If it is fine, sir.
Oh, okay, okay. No issue. I'm just looking for another chairperson
Okay, sir. Thank you, sir.
to add him. Actually, he is there, but I'm not able to press him out. Justin and Chetan, may I request you just leave and join it again? Dr. Ranjit, if you are here, then please help me to identify you.
Good afternoon, Bhupinder.
Yes, sir.
I'm audible, right? Yes?
You are audible, not visible.
Okay.
Hello.
Okay, yes. Hi.
I was not finding these options.
Actually, in the webinar mode, only panelists have the privilege to do
I
all
am
those
checking
things,
for that. I
and
logged out twice. I
others
logged
just
out twice.
can see.
Okay, now I am visible, right?
Fine. So,
Hi, Arif.
okay. Meanwhile, that these our speakers are preparing their
All right, no problem. Let them take it.
setup and all,
Uh-huh.
I would like to utilize the time to welcome both the chairs. So, our first eminent chairperson is Dr. Ranjit Pillai. Usually, I make that mistake R-A and R-E. So, I'll Ranjit R. Pillai,
That
Associate
mistake is there
Professor
in
in
the
the.
brochure also.
Yes, I realizes just that I made the same mistake. Actually, in my contact also the same mistake. So, I do that, but I'll try to improve it in the coming future.
That's
So,
okay.
sir is working in the Department of Psychiatry as a faculty in the psychiatric social work, and he has been associated with several institutions in the teaching faculty positions from the south to north. Now he is in the PGI Chandigarh, and he is having a very good number of publication to his credit. Now he is running PhD programs in his institute in the psychiatric social work, and I'm not going to take much time. Otherwise, it will take complete 1 hour
Better.
to finish. Okay, so coming to the next, Dr. Arif Ali, one of my senior from the very beginning when I started my MPhil, means when I started my journey, he was my mentor, teacher, and roommate. Now he is additional professor in IBHAS in the Department of Psychiatry, well-known person in the field of psychiatric social work, and well-known person in the field of research. So today's session would be focused on the basically family intervention mode, and that I thought that you both, even that executive committee thought that you both would be the good resource person to chair and add on to moderate this session. So we have three speakers, Mr. Ataullah, Ms. Megha, and Ms. Khushbu. All are from Central Institute of Psychiatry. They are psychiatric social work tutors over there, and rest is over to the chairpersons and the speakers. Thank you.
Okay. Arif, would you like to start or should I?
Yeah, start, Ranjit. Yeah.
Okay, thank you, Dr. Arif. Yeah. So good afternoon to all. We are going to have a symposia now, and it is on a topic which I myself is very much interested in.
and it is titled as Practicing Psychiatric Social Work in Indian Families. Okay, yeah. Family is one of the area where I generally like to, I prefer, I take a lot of interest in working with families, and another is like I would like to talk on this topic. Thank you, organizers, for making me as well as Dr. Arif Ali, my classmate and colleague for this session. So we have three presenters as had been introduced, Ms. Meha Atri, Kushbu Shah, and Taula will be making their presentations, and then perhaps after their presentation, how much time would you require each of you?
So 20 minutes. Sir, am I
20.
audible?
Yeah, you're very much audible.
Okay, thank you, sir.
Maybe this is a 1 hour symposia.
Yes, sir.
Will we be having a question answer session at the end?
Okay.
And I'm asking you, would you mind taking up some questions, if at all there are any
Yes, sir.
questions?
Sure, sir. In the last, towards the end, sir.
Okay, so then we should have some 5-10 minutes, maybe at least 5 minutes.
Okay, sir.
So you can adjust your presentation accordingly. All right.
Okay, sir. Okay, sir.
So
Thank you, sir.
we would like to listen to you, and you can start your presentation.
So should we start right now or should we wait for 5 minutes?
I think you can start.
Okay,
It's
okay.
time.
Okay.
It's time, so yeah.
Okay, sir. Okay, sir. Good afternoon, everyone. My name is Kushbu Shah. I'm a psychiatric social work tutor at Central Institute of Psychiatry. I would be welcoming you to this symposium. The topic of our symposium is practicing psychiatric social work in Indian families. Offline, online, hybrid mode. Are we really ready for it? So, it's not moving. Okay. So I would like to first put forward the objectives of this symposium. Thereby, we will be starting by our presentation. This symposium is going to discuss about the paradigm shift in the treatment modality from offline to online to hybrid mode. So first we will be discussing about those things, and then we will be going towards the benefits and limitation of involving the families with psychiatric illness in the treatment procedure. What are the strategies in Indian setting? With the Indian context we are going to talk about. So I am going to be the first presenter, and my topic is engaging Indian families in tertiary mental health care setting in offline mode. So it's very interesting to know that ki family is same everywhere, yet it is not same anywhere, as said by Nathan Eckerman. And since we are talking about Indian setting, we should be quoting our Indian authors too. So Iravati Karve in 1953 spoke, family is one of the three most important institutions for understanding Indian society. So when we see Indian context and the family research in India, so Indian studies of family was focused on family pattern. When it initiated, it started from family pattern and then slowly rather than family dynamics, which the Western culture initiated with the family dynamics. But our culture, our Indian context was never initiated with the family dynamics, but rather family patterns. If we see family research in India, it has overgone a course of distinct phases, which have their own specific themes and a specific question to each phase. Understanding these phases have led to the belief and established the belief that Indian family was essentially joint. This belief was initially came from this evolution of family research in India, which initiated in 1950s. So two of the belief systems established in this particular family research. First was the Indian family was essentially joint, and second is following the industrialization and urbanization, Indian family was replaced by a nuclear family. These were the two beliefs which were established by these family researchers, which was conducted during that period. So if we really see what family research in India and trace the trajectory over different phases, the very first phase was the Indological study of ancient Hindu text, and which was followed by change in family structure and change in family processes and dynamics. So it's very naive to say that we don't We have not touched upon family dynamics part. We have touched, but the thing is, initially it initiated from Indological study of Hindu text, which stated that from this particular research phase, we got that joint family was portrayed as the characteristic feature of Indian society in the Indological phase. Then when we come to the second phase, in this phase, there were three important connotation or three important beliefs which came about. First one was the industrialization and urbanization will lead to the development of nuclear and conjugal family system, where the importance will be on the conjugal marital relationship. Their bond will be more stronger than that of in a joint family. In this phase only, the second stage was structural changes has occurred, but the functional jointness was not disrupted, rather than it continued. So the second belief was the structural changes has occurred, but the functional jointness has not, it continued. The third belief which came from the second phase was the irrespective whether we went through the industrialization or urbanization, the persistence of joint family continue. So, and the third phase, which we are talking about, is the alternative forms of family structure in India. It talked about different rapidly changing families like single parent family, dual learner family, adoptive family. If we see today, the LGBTQ family and all. So from this phase and from the researches which I have undergone, I have understood the Indological phase has presented us with the two beliefs. One was that Indian family system was a joint family. And following the urbanization and industrialization, we became nuclear. But it is not that so. If it has been so, in the very first census of India in 1871, I might be mistaking in the exact year, the number of nuclear family during that time was the highest, was more than that of joint family. And also from subsequent literature of Desai, Gore, and other people, we have also found that the people who belong to upper class and upper caste, they were having a joint family system because they can afford that thing. And simple lower caste and lower caste people cannot afford that particular setup because of high affordability rate. So they opted for nuclear family. So nuclear family altogether is not a new concept to India. It existed in our ancient literature also, ancient India also. But from these phases, we understood how these family have undergone different family patterns in India, family changes. Now we have to understand that socio-cultural milieu of India is going through different pace and going through different family structure, different family functions. So it is taking us to progressive increase. Up now it is undergoing progressive increase in nuclear family, more, and that too more in urban setting. And it is associated with decrease in number of household members, also associated with decrease in age of house head. Earlier, which was a jointness of male-headed membership, now it is being changed to less number of house head people. Change in power structure is seen nowadays, and increase in household headed by females is seen nowadays, and change in traditional gender roles is also undergoing these men. And this is not my data, but NFHS says like this. Now, why we are talking about Indian family system, Indian structural family system, Indian functional family system, and why we are talking about this change from joint to nuclear, now from conventional to nuclear. Why we are talking about this? Because it's impacting, it's having a great impact on psychiatric illness, because family is the base of every individual. It's the basic unit of society. It's the basic functional unit of society. It's also the place from where the people are getting socialization and getting functional assistance to bring or get better in their future. So psychiatric illness engaged and importance of family engagement thus becomes very important. So first of all, if we see, social intervention is not a new concept to India. Social intervention with families to help them cope with problems have always been a part of culture in variety of rituals. It's present in our ritualistic culture. For example, somebody dying and the rituals persisting to overcome that bereavement phase from grief. That is an example of social intervention, which was conducted by all the family members. So it's not a totally new concept. If we see family therapy or family-oriented psychotherapy, it definitely has been brought up by westernized concepts, and these being the pioneers of them, of the family therapy, and also these important concepts. But when we speak of Indianness of family therapy, it initiated in the same time when the westernized culture was talking about family. So our own in 1950s, our own Dr. Vidyasagar initiated involving the family. We were the lead to involve the family in mental health and treatment procedure. So Vidyasagar was able to involve the families of patients. He was able to understand that in understanding and taking care of patient with psychiatric illness, it's very important for families to contribute and get involved in the treatment regimen, to support each other through group participation. He understood the importance, because through the experience, observation, learning, and practical assistance, he was able to understand and recognize the importance and impact of family. Vidyasagar also found that involving the families has significantly reduced the hospital stay, increase the acceptance of patient by the family member, and enhance the family coping skill altogether. And this was after this initiation, we will see different people, different institutions coming together, involving family through different intervention like family education, family counseling by Mental Health Center Vellore, followed by NIMHANS, which started Family Psychiatric Center in 1977, and subsequently, and it also opened family training diploma courses. Now, why we are talking about family? Because role of family in mental illness becomes detrimental. Detrimental in what concept? In the progression, in the treatment, and in the improvement. And it's just not limited to family therapy, but also the family involvement, the engagement, and family acceptance. These all are clubbed together and taken. Here, psychiatric social plays a very eminent role. As a part of interdisciplinary team, he acts as a bridge between the mental illness, their family, and he facilitates the service, care, and accessibility of those services to the family members. He acts as a service agent and ensures the community reintegration in the process. If we, in the same line, if we see the interdisciplinary team, the psychiatrist, the clinical psychologist, the psychiatric nursing, we see all of them have an individualized approach to approaching patient, be it pharmacological, be it non-pharmacological. But psychiatric social worker has altogether overall family intervention and family engagement with the patient and caregiver party. Here, through non-pharmacological management, through different things, family assessment, family intervention, family support, advocacy, rehabilitation, disability, welfare counseling, community awareness program, home visit, he tries to bridge the gap. And he works with the family. He or she works with the family. If we see psychiatric social worker, in the inpatient family, he engages family bilingually. First, through inpatient family engagement, then through outpatient family engagement. The work done through inpatient engagement can vary across from intake counseling to discharge counseling. But during that particular time, when the psychiatric social worker is engaging with the family, what he is trying to do, he is trying for the to bring about readiness for change in the family member, more acceptance of the patient, acceptance of the current situation involving the illness and family situation altogether in the family. He also deals with the unwillingness and resistance as shown by the family members, in case he may also have to work and look upon to the dumping of patients and reintegrate him back to the society. addressing any myth and misconception if he is finding out in the family, imparting the correct and right information, addressing any faulty attitude in family, in hindering the treatment procedure or treatment regimen of the mental illness. Also, he will invoke family to be a part of the treatment team by invoking family as a co-therapist, family member as a co-therapist. Therefore, we go for identifying primary caregiver in the family who can look after or who can initiate taking responsibility of supervision, regular medication, follow-up of the patient, and also, if needed, environment modification. Similarly, in the same line, outpatient family engagement, if we see, outpatient, we see patient in OPDs and PSU, psychosocial units. There we have to address the family concern and family issues, the utmost family issues which are causing distress to the whole family and a person per se, and go for a family intervention, maybe basic and specific information which can be imparted to then and there, here and now situation, to here and now situation. Whereas in inpatient family setup, we can go by a long procedure, we can call family again and again. Outpatient setup also give us liberty to do the same thing, but the cost of coming again and again and again and again will cost so much money, and affordability, accessibility, availability of the same can not be ensured. Disability welfare counseling, legal aid assistance, and disability certification are the other things which a PSW do in an outpatient basis. But what are the target area for family engagement in psychiatric social work setting in outpatient department for improving the problem solving ability of the families? If the family issues are arising because poor coping, poor problem solving ability, we have to improve upon that thing. Educating the family regarding the illness, modification of the family communication pattern, because it will have a great impact on expressed emotion, and expressed emotion can be a great influencing factor for the relapse of a patient. Then family guidance, then lowering the that is what connected to family communication pattern was lowering the expressed emotion of family member towards the patient. Manipulation of power alliance within the family, if at all it is required. Expanding the social network, social support, and providing crisis intervention and supportive therapies to the caregivers or family members. Now, these are the things which we were talking about, the families which we see on offline basis. But apart from this, psychiatric social worker also face some problems. These problems may range from being an overeager to help, at sometimes the new naive therapist being energetic to help the patient. They might be pushing forward the family members too hard. They may be more eager to help and to help in all the aspects to completely vanish the problem. But it is not like so. Being over eager to help the patient or the family can sometimes be counterproductive. Similarly, a poor leadership, where rather than we being like what we have said, like what we have seen is, first we were in the initial stages of treatment planning, first we were dealing with compliance, then the concept of adherence came, then the concept of concordance came. Now we both, the party and us, we both have to sit together, chalk out, and deal with what issues together we want to address, and how do we want to address. We just want to act as an agent for that, not as a person to give instruction, to guide, or to supervise. So poor leadership can sometimes be counterproductive. Similarly, not immersing or engaging or fear of involving in the family members can also be a counterproductive factor for the PSW to work with the family in Indian setting. Not including all the family members for the session can also be the important factor, because we may educate or we may do a family intervention with one particular person. He may be trained enough and he may be doing well enough to prevent the relapses, but the problem has not initiated in this home setting, hospital setting, but in the community, in the family. He has to go back and he has to reintegrate to the society and community from where he has come. And that community and that particular initiating from family, that family is not composed of one member, not necessarily be composed of one member, but multiple people. So only treating and teaching one people won't be enough. Then not including all the family members for session can be counterproductive, because one person can be doing the and allowing, one person may be following, and other person may not be following the same. Not involving members during the session. It's not like if we are talking to two or three people at the time in a family session, and we are only involving with maybe one person. So not involving all the members in a during a session can also be a counterproductive fact for a psychiatric social worker to do. Taking side with any one member, guarded families, communicating with therapists outside the session, ignoring previous work done by other therapists, and getting sucked to the family affective state and mood. Difficulty in improving family communication pattern. This communication pattern difficulty, because free communication of thought and free communication of feeling get hindered or it gets impacted due to rigid family structure, and that could be understood by us. But due to this non-free communication of thoughts and feeling, family problem arises, to which psychiatric social worker has to deal, for which he has to first do the assessment, then carry forward with the intervention plan as per suited by the patient or the family member. Now, problem with family engagement in offline comes while what attitude the family members are having towards the family engagement in the mental illness, and how it is hampering the treatment procedure. The very first thing we go and see in family engagement is the attitude of rejection. This ignorance, this non-compliance, non-acceptance of treatment regimen, they are not ready to accept the fact that the symptoms or the symptom profile or the syndrome with which the patient is
Sorry to interrupt you, Ellie.
Yes, sir.
You need to go a little bit fast. It's
Okay,
already
sir.
20
Okay.
minutes.
Okay, sir. Okay, sir. I'll be mindful, sir. Sorry, sir. Sorry for that. Then attitude of overprotection, which overprotection, that is shielding, that will lead to codependency and enabling behavior leading to interdependence. Not the independence part won't be touched. Then attitude of overprotection, expectation, unmet expectation, which will put an unrealistic expectation for the quick redressal of problem. Then attitude of self-blaming. These are the attitude a family members might be having, which will hamper the family engagement in mental illness. Following which we will be discussing the benefits. Now I am coming towards the end of my slide, where we will talking about the benefits and what are the limitation of family engagement in offline setting. So benefits we are talking, so it will surely engage the family in treatment procedure. Offline mode ensures the engagement of family. It will reframe and detoxify family issues. It will bring about readiness to bring change and the responsibility of onus onto the family for acceptance and cooperation. Healing in family adaptation to change, enhance communication, improving the overall functioning of the family, preventing relapse and ensuring the follow-up, ensuring continued treatment. These are the benefits, followed by family helping as a supervisor, encouraging participation, and providing an environment conducive to promoting recovery and reducing the disability. Also, it ensures the offline setup ensures family support, where it gives things to ventilate, to arise shared understanding, explore alternative coping strategy. If we see the limitation on the other hand, the very first limitation comes is difficulty carrying out family session with all the family members, where accessibility, availability, and affordability becomes a problem. Then inability to track or ensure compliance of and regular treatment, including follow-ups, again is a problem for PSW to face in offline mode. Then understanding and the language barrier. Not everyone can understand everything. And having a multilingual team, interdisciplinary team we are having, but multilingual team is a bit difficult at all the possibility. In endocultural issue, also jeopardize the therapy outcome. If we are not culturally sensitive and insensitively, unknowingly we hurt the cultural sentiments of that particular community. Then perception of family members affecting the seriousness and commitment to therapy will also be determined by the therapist experience. Me being a therapist, my age, my sex, my cultural background will give an idea to the upcoming family which is coming to me, and they having a perception this person is not apt enough, good enough for me to take a initiation or good enough for me to take a session, will also impact and act as a barrier. And multiple and frequent, and it will, since these are limitation, will act out and the family will lose its track and it will lead to multiple and frequent relapses. Here, I would like to end my presentation and seeing this thing, how we can bridge this affordability, accessibility, and availability track. I would like to invite Ms. Megha Atri to throw some light on how engaging families through online mode is giving us some direction.
Thank you, Kushbu. I will request Nega to complete your presentation in 15 minutes, say by 4 o'clock, if that is okay.
Good evening, all the chairpersons and other faculty members. I will be continuing with this symposium presentation, and I will try my best to complete this in the given time. So, moving forward, treating families in online mode, potential benefits and challenges. So, for now, we have one of my colleagues just presented ki how can we engage families in offline mode, in person psychotherapy and psychosocial interventions. So, overcoming the barriers of the offline mode and in person mode, we are moving forward to the online mode. So starting with the telemedicine refers to the consultative services to individual patients and transmission of information related to care over distance using telecommunication technologies, and it incorporates direct clinical, preventive, diagnostic, therapeutic services and treatment, consultative and follow-up services, remote monitoring of patient and families, rehabilitative services, and the patient's education. So this definition of telemedicine I found as it include many of the aspects of the telemedicine services. So talking about the telepsychotherapy, it refers to the provision of psychotherapy services using telecommunication technologies, including email, text messages, video conferencing, online chats, messaging, and internet over the phone. So this definition is as per the NIMHANS guideline given by 2020. Telepsychotherapy is also known as online therapy, e-therapy, tele-mental health services, and cyber psychotherapy. Moving towards, if we see if this is a new concept or the not, so telepsychotherapies and the telemedicines has been a long history. Before earlier also, apart from the in-person sessions, if we talk about the psychoanalysis timeline, so at that time also letters and the mobile phones, letters also sent to the patient and the family members for their follow-up and the continuation of the services, to ensure the continuation of the services. Then after that, with the passage of the time and the technology's advancement, letters to mobile other mode of communication, and then mobile phones, and then now we also use our internet. So arrival of the internet digital age was 2000 around, when globally there was excessive use of the internet services for different type of the exercises. Then if we see at that time also, before the COVID-19 also, if we see use of the telepsychiatric services or use of the telephonic or video conferencing services for the impartation of the psychosocial services was not in much used. Not even psychosocial, but telemedicine also, it was not widely used. But after the COVID-19, when there was restriction on the physical exposure of the patient and the therapist, and exposure of the patient and the other mental health professionals. So to ensure the health of the patient and the family member, there was boom in the telemental health services via video conferencing. So now, what is the process of engaging families online? So first of all, we have outpatient services where there may be new registrations of the patient, and there may be old patients coming for visiting for the follow-ups for their medications and other psychotherapeutic. Then we have inpatient services also. In open wards, the family resides with the patients, but only limited number of the family members reside with the patient. So if we need to discuss and to explore further with the other family members also, so we can opt for the online services. Then close ward, there are some close wards also in every mental health establishment where the family members or the are not present with the patients for the longer duration of the care. So at that time also, in that circumstances, online services are beneficial for us to connect with the families. And similarly, families of the abandoned patients, those patients who do not have any family or whose families are not willing to take back them after the treatment. So in that scenario also, online passage is the only way to connect with the family in a better way. How can these families be referred or approach us? So there can be self-referrals also, referrals from other mental health professional like psychiatrist or a clinical psychologist or other mental or other health disciplinaries. And PSWs, if can also approach directly to the families if a patient is allotted for the psychosocial intervention and assessment. Then what are the benefits to the psychiatric social workers of having a online mode regarding this? So in case where home visits are not possible, we can we can go further for the online sessions with the family to increase the involvement of maximum family members in the treatment. As we just discussed, ki inpatient services also, only limited number of the family members stays with the patient only. So to have the better understanding and to know more regarding the family environment, live understanding of the family environment and interaction patterns, it is beneficial to go for the online sessions. I remember when I was having a session with one of the family, the patient was admitted in CIP, but after the discharge of the patient, when he went to the family, his home environment, then we took a follow-up session for the patient to ensure ki whether the family intervention done telephonically and video call was effective or not. So it was very effective to see the patient and the family member in their natural environment interacting with each other, and before, as compared to before they were here during the admission of the patient, and to understand the living conditions of the patient. Then benefits to the family: easy accessibility, time and cost efficient. The online sessions are really efficient in each aspects in terms of the time and cost. Patient and the family do not need to travel far away for the benefit for just for the sessions. Their money can be saved, and there are families where only chief earning member of the family is the head of the family and only caregiver. So in that scenario also, online sessions can be helpful in continuing services. Special populations, like if the patient or the caregivers are adolescent victims of the abuse, dependent family members, like if there is a family comprising of the patient, primary caregiver and dependent grandmother or grandparents or other dependent member with other chronic physical illness. So in that case, online sessions will be beneficial. Ensured continuous care, geographical area. Sorry. Now moving forward to the challenges for the families. Socioeconomic status, low socioeconomic status may somewhere hinder the patient and family to approach for the online sessions. Then age, there might be the possibility like if the patient or the other family member are older or adolescent or young population where they have no knowledge regarding how to use this technology. Then lack of availability of the adequate gadgets and lack of knowledge to use. Again, due to the low socioeconomic status and the age factors or literacy rate of the patient and family member. Then geographical area, network connectivity. We at the one hand are saying that we are connecting the families and patient through online mode in case they are residing in the remote area. But if in that remote area there is also lack of good network connectivity, so again this will hinder the approach to us. Then confidentiality and privacy, like if we talk about the in-person sessions, then if we are having a session with the family members and we need to discuss separately with each family members separately, so in in-person session we can ask the family member to go to another room or to wait outside. But in case of the online sessions, we cannot ensure the confidentiality and privacy of the patient and the other family members in online mode, because they are at their home and we do not know if they are adhering with the rules and regulations set before the sessions or not. Then unwillingness to continue treatment. There are multiple families I have seen which even if given the pros that in the government setup, the psychotherapies are free of cost, there is no money to be taken from you, still there is unwillingness to the continue of the treatment online. But there are challenges for the PSW or psychiatric social worker also, like lack of knowledge regarding the use of technology, where unwillingness to learn regarding the technology is also a factor. Then lack of adequate infrastructure. For conducting a online session effectively, we need a good broadband connectivity of the Wi-Fi. We need a good and calm setup where there should be low noise level of the during the session. So adequate and friendly infrastructure we do not have at everywhere. Then increase work burden. Mental health professional and patient ratio का जो disparity है still is very high. So in given the time 24 hours, we have to see the online sessions also. We have to see and take the assessment and intervention with patient in person also. So due to overwork, due to overburden of the work, there are some barriers for continuing these online sessions on daily basis. Therapeutic alliance. I have gone through so many literature recently that which has the which were focused on the lived experiences of the therapist conducting the couple and family therapy. And in those articles, it was the fundamental issue faced by them that the therapeutic alliances which are made and can be established in person, that cannot be the same quality in online aspects if we see. So developing therapeutic alliances are still a challenge. Then hindering understanding of non-verbal cues. In person, we can observe, we can see, and we can regulate the session more effectively in natural environment as compared to online sessions. Engaging family members connected with different gadgets at different same time. So see, if we are conducting a family intervention or family assessment, and all the family members are at remote areas or different areas and has joined their session at the different places, so it will also be somewhere hinder, create obstacle, because we have to manage the connectivity, internet connectivity, and the um, dynamics of our interaction pattern during the session. Then not suitable for emergency crisis situations requiring in-person sessions. As per the guidelines given by the NIMHANS in 2020 for the telepsychiatry, and it is written ki if there is emergency situation or the crisis situation or the where patient and family need in-person sessions, we as a mental health professional, PSWs, cannot continue or cannot ask the family members to continue sessions online only just because they are so feasible and they are so comfortable in online sessions. So wherever we think we need in-person sessions, we have to motivate and counsel the family member, educate the family member regarding the same. Then changes in work-life balance and digital fatigue. This is also I have observed after a various review of literature that many therapists and many mental professionals has described that their work-life balance has been uh, changed drastically after the COVID-19, since the work from home and the hybrid mode and the all these nature of the work has been changed. Then there are some prerequisites for the PSWs for before conducting a family sessions online. First is establish a comfortable online space. Just we establish in while conducting an in-person session to ensure a quiet, private, and comfortable environment for all the family members. Then choose a suitable platform, whether Google Meet, Zoom, and sometimes if family member do not know how to use all these things, then we have to switch to the normal WhatsApp video calls as well to complete our purpose. Set clear expectations regarding the online therapy process, boundaries and confidentiality. And again, in case of need, you have to come for the in-person sessions also. Encourage active participations, engage each family member in the sessions, use icebreakers, individual check-ins. So it should not be like the family members are sitting quiet only. We have to engage all the family members for the assessment and intervention as well. Use visual aids, then foster a sense of connection. As we discussed earlier, there is a challenge of establishing therapeutic alliances in online mode. So we need to work on this, how to boost this and how to improve this obstacle. Be flexible and adaptable with the time and with the patient and families need. Maintain regular sessions. It should not be like if we are conducting online sessions, we should do once in a month, or like uh, uh, should take this very casually. Like we are adhering for our therapeutic alliances and therapeutic intervention method and guidelines in in-person mode, we should also align the same manner in online mode as well. Monitor progress and feedback. Regularly assess family need and adjustment your approach as needed. Then ensure confidentiality and security of the patient and family both. Now, on the basis of this, I have
Can you wind up in another 2 minutes?
sir, this is just last slide. The recommendations on the basis of the all the review of literature and the personal experiences, recommendation include proper adherence with the guidelines by the professional. Like the NIMHANS has released the guidelines for the telepsychotherapy for each mental health professional, being psychiatrist, CP, or PSW, or psychiatric nursing. But I am not sure and neither I found any efficacy and the review any article which was reflecting the adherence to those guidelines and but success or the barriers. Then continuous supervision and training for conducting online sessions is required for everyone, whether scholars or tutors or other faculty members also. Promotion of teleservices during the community awareness programs, during the outreach programs, or during the intake counseling of the patient as well. Promoting other essential assessments online like ideas as well. So this is, I am hoping this last point in upcoming years or in upcoming time when the families are, with these, I'm hoping in future also like we are exploring family dynamics and doing the interventions, and due to the dependent family members where family members cannot come for the ideas, there might be some possibility in future the ideas will also be administered online so that the social security and all the benefits can be given to the patient without any barrier. So with this, I am ending my presentation here only with the word that where at the one hand technology is separating the families, but wise use of the technology can also combine the families for their better functioning and healthy functioning for the future. Thank you. Now I would like to invite Mr. Ataullah for continuing the symposium. Thank you.
Yeah, thank you, Megha. And Ataullah, I would request you to be little fast in your presentation because we are already running out of time.
Yeah, thank you, sir. Sure, I'll take care of that. मैं क्या मीटिंग से बाहर आई नहीं? Good evening, everyone. I hope my slides are visible and I'm audible and my visual must be clear as well.
Please go on.
Hello. Hello.
You are audible.
Yeah. Yeah, thank you very much, sir. So from here onwards, I would like to continue the symposium with the topic Paradigm Shift to Hybrid Mode with Indian Families, Access to All. So before the starting of my talk, yes, my two colleagues have already shed their lights on how we used to practice working with families in the offline mode and in the online mode. So in my presentation, it will be the mixed of both of it. So starting with the introduction, no doubt we cannot deny the fact that in-person therapies are best and is regarded as the most effective mode of therapy. But we also cannot deny the other fact that the online therapies, which has been in trend now and which are very much helpful during the pandemic time, worked a very wonderful in the accessibility and accessibility of mental health field among the general population. Yeah. So and family intervention and engagement has been long been a cornerstone of mental health treatment, which particularly families grappling with mental illnesses. So we have seen that traditionally conducted in person and the mode of therapy for deliver and has undergone substantial changes due to advancement in technology and the COVID-19 pandemic as well. So, with this, the COVID-19 has been accepted that the integration of technology into mental health care, and it promotes a shift also from traditional in-person family intervention to the online, and nowadays we are having hybrid mode as well. So this transformation is particularly significant in India, where families dynamics and the cultural norms profoundly influences somehow the therapeutic practices and the slides all and the outcome as well. With this I would like and their impact on therapeutic outcome with a special focus on the role of psychiatric social worker. So let's understand what is hybrid mode. So a hybrid mode of psychotherapy, as I have discussed earlier, it's a combine of the in-person offline therapy and the online sessions. So it's a combination of both in-person and online telepsychotherapy or online sessions to provide a very flexible and comprehensive approach to the treatment with families or with family therapy. And this model also give the leverages to both the therapist and the families this advantage that both the modalities offers a more adaptable and accessible form of therapy as well. So let's have a very rough historical context and evaluation of all the three modes of the treatment with family engagement. So in-person family intervention and engagement, historically, we have this in-person family intervention and engagement with a very standard practice, which offers a space for therapists to observe the family interaction, assess the dynamics, and intervene very effectively. We have lots of meta-analysis, we have lots of research studies, which says that the offline therapies are very much helpful to make changes in the families as well. And this mode also allows and helps the therapist to read and to help in many ways, and it allows for non-verbal cues, the physical appearance, and the control environment, which are very critical for rapport building and the trust as well. Coming to the transition to online therapy. So when we are talking about transition, so it's not when the COVID pandemic necessitates this rapid shift, but it has been very the history of online therapy, the history of telepsychotherapy, the history of telemedicine is from very in 20s or before COVID-19. But the COVID-19 pandemic necessitates a rapid shift to online modalities and highlighting both the potential and limitations of virtual therapy. But while having online family intervention and engagement in India, it had a we have to adapt the issues like digital literacy, internet accessibility, and privacy concerns. So these are few limitations as well, which comes while working with families online or while working with families telephonically or while working with families in very asynchronous manner as well. So this shift has the transition of hybrid therapy model. So as the limitations of both in-person and fully online therapy become apparent, so here comes the hybrid model, which emerges a very promising solution. So hybrid therapy combines, as we have discussed, key benefits of both face-to-face interaction, such as establishing rapport and non-verbal communication cues with the flexibility and accessibility of online session. And for Indian families, basically, and especially this model somewhere accommodates the preferences for very personalized care while leveraging the convenience of digital platform. So, like whether when the families are available, when the therapists are available, so this comes, the hybrid model comes with very this leverage that it makes convenient for therapists and the Indian families as well. So cultural considerations are there in Indian families and or family therapy. So while we were talking about family intervention or engaging the family into the therapy, into the treatment in India, and we have to navigate the intricacies of cultural dynamics, include the hierarchical family structure, gender roles, and stigma associated with mental illnesses. So these are the factors which somewhere influence the acceptance and effectiveness of different therapy modalities, including online, including offline, and the hybrid as well. Okay, so in person, while we were talking about the cultural competencies and these things, so what are we looking for in person? So in person aligns well with the cultivist culture of India, where family cohesion and the face-to-face interaction are highly valued. So that's why we termed in-person therapies as the traditional therapies as well. And this method supports the incorporation of culturally specific practices and rituals into the therapeutic process, enhancing engagement and acceptance. In-person sessions provide a very conducive environment for building trust and addressing complex family dynamics as well. While we talking about online therapy, as Megha was also speaking about this key, while we were talking about while we were performing doing the online therapy or telepsychotherapy with the families, so somewhere it has benefits, it has limitation. So it gives us challenge which is related to technology adoption, privacy concerns, and potential miscommunication as well. So the anonymity provide, and what are the benefits? So here the benefit is the anonymity which provide by online session can also reduce the stigma and encourage participation from those hesitant to seek help in traditional settings. And the flexibility of online therapy, which allows for greater scheduling convenience. So what time the therapist available, when the patient is available. So this scheduling convenience is very much uh, significant in online therapy, in telepsychotherapy, and which can be particularly beneficial for busy families. So when coming to the hybrid family as hybrid family has the leverages of strength of both in-person and online approaches. So while we're talking about in-person, so while we were talking about in-person sessions, in-person family engagement, so we talked how it gives a space for the cultural competency, cultural sensitivity. So hybrid also offers very culturally sensitive and adaptable therapeutic process. Why we need, so coming to the point, why we need hybrid mode of family intervention. We need family intervention because it gives a very flexible thing. We have flexibility in scheduling, we have enhanced accessibility, we have continuity of care, cost effectiveness, enhanced engagement, customization and personalization. So we all have somewhere discussed in the past slides as well, how the patient and the families can flexible with the scheduling when the patient is available with the family and when the family is available. It enhances the accessibility as well. It continues the continuity of care once the patient gets discharged. So once he will be living with the family, so how it is so what are the issues which the family is facing with the patient, and the patient is family and the patient is facing with the family, like adaptation also we can have while we were having hybrid. sessions. So yes, so it's never they think everything has a pros and cons. So basically, while we talking about limitations of hybrid, so it combines. So while we were talking about what is hybrid, so it combines the in-person session therapies and the online therapies. So while we were talking, it is the combination of both of the things. So the limitations also somewhere highlights the combination of limitations of both the therapies in person and online. So while we're talking about technological barriers, so it limited access to technology and internet can hinder the effectiveness of online therapy. So with here, like we have to provide the technical support to the patients and offering alternative solutions as well. We can have a phone-based therapy, which can work as overcoming these barriers. So privacy and confidentiality concerns are there. Engagement and rapport establishment. So building and maintaining rapport online requires very different techniques which compared in the in-person sessions. So psychiatric social worker must be creative in their approaches to engage families effectively, utilizing interactive tools and creating a structured and flexible online environment which can enhance the engagement. So we can do this by regular check-ins, interactive activities, online or in person, and personalized approaches, which can help to build a very strong therapeutic alliance between both families and the therapist. So here we coming to the role of psychiatric, where we are in the hybrid mode. So apart from whatever we do, so we are specialized in assessing the psychosocial need, facilitating family intervention, and collaborating with multidisciplinary team. We as a psychiatric social worker also our role extends beyond the therapy sessions as well. So we work as advocates, advocacy, psychoeducation, community outreach programs. So while we were doing all these things, so we can enhance ourselves by developing the ethical practice of psychiatric social work, which somewhere contributes to enhance the mental health literacy and reducing the treatment disparity in India. So our new role, so how we can enhance the disparity of mental health treatment. So we can do one by adapting to online and hybrid models. So we can do this by training and skills development, ethical and confidentiality concerns, cultural competence, so adapting therapeutic approaches to respect and integrate cultural values, which remains very critical to the field. Psychiatric social worker here make a balance between traditional practice and innovative method to provide culturally competent care. So while we are saying traditional practice, so we are talking about the in-person family interventions. So what could be the challenges and strategies in hybrid mode? So first of all is the challenges would be a technological barrier, which we have already discussed, engagement and rapport, which has been already discussed, and flexibility and accessibility as well. So what could be the recommendation and future direction for us? So to optimize the use of hybrid therapy for Indian families, we have to follow these things. So there should be a government initiative which make a digital infrastructure develop, which could be a crucial to bridge the digital divide. Though we have telemanas right now, but still telemanas is somewhere promotes individual therapy. So here I mean to say we need to have something which where the families can himself or herself came for the treatment for their I would say engagement. So additionally, promoting the teletherapy awareness also through public health campaigns, and which can address stigma and encourage the help seeking behavior. We need some culturally sensitive platforms as well to develop online platform with the vernacular languages options that can improve accessibility and facilitate family communication. We can have therapist training programs as well, where we can equip with the skills to conduct hybrid therapy effectively, which include cultural competence and navigating online therapeutic relationship. Future research. So as we Khushbu was talking about in person, Megha was talking about online therapies. So for both, we have lots of research, we have lots of effectiveness studies, but hybrid, if we talk, we don't have any such kind of research which compares that which one is better. Hybrid is better, or in person is better, or which one is better. So we need something in this line as well. So we need to develop some cultural sensitive online tools as well, which we were talking in the past slide, and the training programs as well. With this, I would like to conclude that hybrid therapy presents a very promising paradigm shift from mental health care delivery in India, which particularly while we're talking about families with members of experiencing mental illnesses. So here, psychiatric social workers with their unique skill set and focus on family dynamics and well positioned to play a central role in the transformation. So by addressing the challenges and honing their technological expertise and remaining cultural sensitive, we can unlock the full potential of hybrid therapy, ultimately creating a more accessible and supportive mental health system for Indian families. So with this, I would like to end my presentation over here. Thank you, everyone.
Thank you.
Yeah, thank you to all the three presentations. Yeah. Ranjit, you can say something.
Go on, please. Go
Hello.
on, Doctor. Go on.
Yeah. So before giving
I think you're mute, Dr. Arif.
Sir, you are mute. Please
Please
unmute
unmute yourself.
yourself.
You are audible but not clear.
Yes. Thank you to all the three presentation. Before giving our feedback, I request Bender if there is any question from the audience side, so they can address those issues. Bhupender?
Yes,
Is there any question in the
actually,
chat box or
yes, there are three. First one is have access to internet. What will be the alternative? Second is in the remotest areas where people don't, again, in regard to internet. And third one is if any family does not have caregivers, then what you suggest?
The thing is,
yes.
any patient do not have caregivers, or she might have meant his patient.
Yes, probably it is talking about patient who is not having a caregiver.
Maybe the presenters can take up the questions.
Yes, sir. Yes. Thank you. So, like, first question was if while we were
Patients,
about
if the patient do not have caregivers, how to go about with family intervention? But that's the question, I believe.
Yes, sir. So, taking your first question into consideration, what if we were talking about far away areas as well? So, where there is no internet connection.
Sorry to jump, but be brief.
Okay, sir. Okay. So, there has been a very good number of datas which says that every individual, so more than 60 to 70% of Indian population, mainly if from age between 25 to 60, have mobile phones, have data, have internet. So while consideration these numbers, so I can say, sir, we have the internet connection, we have the network reach.
She is asking about the other 40%.
Okay.
So for that population, we have also satellite clinic and mobile clinics run by the
नहीं, ऐसा नहीं है. I mean,
other.
accept the fact that there is a divide existing. So yeah, there offline is the only option. They will have to go to any nearby mental health facility to avail. As long as, I mean, the things are changing, connectivity is increasing.
Yes,
So
yes.
hopefully this will reach all the population in the coming years. But we have to accept that there is a divide existing. which is getting minimized as days passed on. Till that time, DMHP is an option. The physical DMHP, the local mental health resources and facilities available. Perhaps there are the options available. I mean, India is a big country. There are difficulties. We have to accept that. That's okay. The second question, patient does not have caregivers. I mean, there is no family intervention. We have to think about intervention that is possible at the patient level, individual level. Caregivers are not available. Keep exploring the possibility if they have a caregiver and if they can come down or they can be contacted. I mean, all your options, offline, online, hybrid, all those things can be explored.
Sure, sir.
I think I answered for you.
Thank you, sir.
Any more
Yes,
questions?
so I think any more question? Yeah. Any more question, Bhupinder?
No, sir.
No. So I think we should give our feedback, right, Ranjit?
Please go ahead.
Yeah. So because time is less, so just I will say a few things like once again, thank you for your presentation, right? But you have already discussed about what are the challenges faced by the family members in the context of mental health issues, and you have also highlighted some critical areas of concern, right? But I would like to give some constructive feedback so that you can enhance your comprehensiveness and clarity of your presentation, right?
Yes, sir.
Hello, I'm audible, right?
Yes, sir.
I think we lost him.
In Delhi, it seems raining heavily.
Yes, sir, heavy rainfall. Yes.
Yeah.
Sir, when
Can
he
I
was asking, I'm audible, he was audible, but soon after that, he was not audible.
Go ahead,
Yes.
Arif. Dr. Arif, we can hear you.
Yeah. So, see, while you touch upon the problem that's related to family with mental health issues, what I feel a clearer and a more structured explanation of the family dynamic was missing. And that would be beneficial for the audience, those who are attending this, especially the specific models and approaches to understanding these dynamics could have strengthened your argument and had provided a solid framework for the audience, right? So that was missing. The family dynamic part. I think you have not touched what I was expecting with the title of your practicing psychiatric social work with Indian family. The Indian family dynamic was missing, right? Then the presentation would have been great benefit. That's very difficult for me. Right. So what I've just like two or three lines like the structures, model, approaches that we as a PSW we generally practice in our day-to-day practice in the mental health setting. That was missing. Just I want to say that was that was missing in the entire presentation. Then the third thing what I would like to point on the reference and citation. Most of the slides were not having the proper citations, right? I think this is a very crucial. If you're commenting on definitions or you're commenting on the problem, it's very important for you to please give a citation. So appropriate citation is also very much important, right? Then addressing the recent areas, right? That was also missing. It's like we have not talked about the relevant areas such as disaster and pandemic or initial, I think, presently talk about LGBTQ family issues. We have not touched about the aging population concern and other special population. So if you talk about these in today's context and how to address them, would have been given a more clear picture, comprehensive overview of your presentation, right? And the role of psychiatric social work. At the end, Ataullah tried to touch about the role of psychiatric social work, but I think it will be helpful to explore the deeper role into the role of psychiatric social work in this setting, right? It's very important. What we're supposed to do, what is our responsibility, duty, contribution as a psychiatric social worker, right? That was missing in your presentation, right? And at the end, like detailed guidance, right, on how that PSW psychiatric social work is able to manage in offline, online, hybrid mode. Which one is more effective, right? So if you're presenting in the symposium, that is also very important. You have to reflect what is more effective for social workers to manage either in offline or online or hybrid mode. So, and what are the specific techniques and the best practices, right, for each mode would have been provided a valuable insight for the audience, right? Especially giving, we're talking about a digital platform for mental health services. So these are my some points, feedback I would like to give to the presentee, right? Over to you, Ranjit. I think my network is very poor, I think.
So you were clear, your audio was clear the whole session. Thank you very much, sir, for your feedback.
Thank you, sir.
Right. Yeah. I think Dr. Arif had given a very comprehensive feedback. Well,
Yes.
I have only one suggestion. And this suggestion is basically from the assumption that you all have experience of working with families in all those three modes, three methodologies which you have actually talked about today. So having said that, it would have been nice if there was a case vignette and then talking about what was the difficulties, plus, minus, benefits, vagera. So that would have given a little more. Whenever is a symposium, it's always a good idea to incorporate one case vignette, one example, which will give a good idea. Okay, that's all. Otherwise, I appreciate you because I'm very happy to see three young budding psychiatric social work professionals whom I have seen as students, now tutors, and doing this symposium. Very happy to see that. Appreciate this initiative and do more such symposium in future also. Okay, all the very
Yeah, good presentation. All
Thank you
three
very
of you,
much.
very good presentation, right? Yeah. Thank you, Bhupinder.
Thank
Thank
you.
you, Ranjit.
Yeah, thank you,
Thank,
Arif. Nice to see
thank
you.
you,
Thank you,
sir.
organizers.
Thank you, both the chairpersons, for sharing the session. I agree with your thought that it was good presentation, but the first presentation taken very much time that derailed my timeline.
Happens. That
Anyway,
all happens.
thank you so much, all presentees and the chairpersons, for your valuable time and valuable inputs. Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you.
We'll come back
So
for
now,
the
with sir, thank you. Now, with the same platform, we are going to move for our last academic session of the day. That is the eighth free paper presentation. And we have two chairpersons for this session. One is Dr. Arunima Dhar. She is presently serving as assistant professor in social work in the Center for Distance and Online Education in Rabindra Bharati University, Kolkata. Welcome, ma'am, to the session. Second, we have with us our another chairperson, Dr. Soma Saha. She is also a faculty in social work, a very interesting field. She is working as assistant professor in the field of means the college is Vellore Institute of Technology, faculty in the social work. So welcome both of you. I'm not taking much time because we are already behind the schedule. So just controlling my words over here and handing over your session to you. Meanwhile, I'll just would like to request the people, those who have to present. Ritika already in here. Sagarika Saha is already here. Hovala Roa is here. But Vicky John Lambre and Pinakshi Kalita is not in the meeting. So if you are in the audience, please raise your hand so that I can add you. Meanwhile, uh, in between, you can start your session, ma'am. Over to you.
Thank you, sir. I think Ritika Rajendra, impact of self-help groups and marketing the products with special reference with Assam. Ritika, are you ready to present?
Yes, ma'am.
Okay, please.
Am I audible?
Yes, please turn on your video and share your screen.
Ma'am, actually, it's heavy raining out here, so I'm not. If I'm turning on my video, I'm getting network disconnection.
Okay, so please go ahead with your presentation.
Okay, ma'am.
Just wanted to add, it's like 8 minutes for your presentation and 2 minutes for the discussion, I guess, right?
Okay. Yeah. Okay, ma'am.
Please try to finish it up. At least make it a target to finish it up within 5 to 6 minutes, because we are already delaying our sessions. So that will be really helpful.
Is it visible, ma'am?
Yes, you are audible.
No, is my slide is visible?
No, it is not. Please share your screen, then only it will be visible.
Yeah, I'm just sharing only.
We can see your name.
Just I have shared it, sir.
Stop it and share again.
Okay, okay. Just give a second. No, I'm not able to share, sir.
Vicky John Lambre. Can
Sir,
you
can you
please?
share?
For now, it is very difficult for me.
Sir, can you please share my
Ma'am,
slides?
can you ask next one to start the presentation? Meanwhile, I'll ask someone to present for her.
I think we can do that. Yes. Who is the next person? It's Vicky. Are you ready?
Vicky John Lambre. Yes.
Yes, you have to unmute yourself, Vicky. You have been muted.
Hello, ma'am. I would like to use my friend's laptop.
Are you using two
at one
devices?
place.
Yes, yes, we're all in one place.
Mute one.
Hello, sir. Can you add Dapimaya Sela as the panelist so that I can use her laptop?
You are still using two devices.
Both devices at same place. Vicky, you have to use one device, or you have to make sure that your second device is in mute and in no volume status. Then only it will work.
Okay, okay, sir. I was asking whether it's possible to put Dafimaya Shala as the panelist so that I can use her laptop
To share this.
to share the screen.
You can share from your end.
Using from the
We-
phone.
Because I'm using my phone, not my laptop.
Okay, okay, okay. All right. The Fimaya, is it?
Yes, yes, okay.
Okay, promoted.
Hello, sir. Am I audible?
Again, the
Hello?
same mistake. You are audible, but yes, please go ahead.
Okay. Good afternoon to the chairpersons and the participant present here. First of all, we'd like to introduce ourselves. We are the students from St. Edmund's College, pursuing Masters of Social Work in our second semester. As the team, we will present on the topic of menstruation, experiences and challenges of adolescents in Meghalaya. My team members are Vicky John Lamare, Poonam Ray, Dafi Mayashallah, and myself, Doreen Lisa Walam. So menstruation is a natural process that every girl undergoes upon reaching puberty. According to various statistics shown in the slide, more than 2 billion of people menstruate around the world each month. The objective of the studies are to explore the menstruation experiences of adolescents, girls, to assess the challenges faced by adolescents in maintaining proper menstrual hygiene. The significance of the study statistics shows that millions of female cannot afford menstrual products and men also drops out from school due to menstrual related problems. In this context, we aim to understand the experiences and challenges faced by adolescent girls in Umulang village concerning menstruation. Now I would like to hand over my presentations to the next presenter, Poonam Ray.
Coming to the methodology, we have employed a descriptive research design to outline the current experiences and challenges adolescent girls face concerning menstruation. We have purposefully selected 100 female students from class 8 to class 10 from two schools in Umulong village. Then, a semi-structured questionnaire was used for data collection, and the process involved several steps. Firstly, the questionnaire was completed and then reviewed by a content expert and a language expert. Then, a consent form was developed and approved by a committee at St. Edmund's College. Following this, a permission letter was provided to the principal of the school along with the consent forms for the parents or guardians of the respondents to sign. Only after receiving these signed consent forms, we proceeded with data collection. Then, for data analysis, SPSS was utilized. Now, I'll hand over to Dafi Mayashila.
Okay, good afternoon. In this slide, we present the major findings from the studies. As shown in the first chart, that is 51% of the respondents in Umolong village did not know about menstruation before they first had their periods. Additionally, as you have seen, 71% of them they are unprepared when before they got their first period, while according to the third chart, as you have seen, that is 58% of the respondents felt scared when they first had their period, and a majority comprising of 76% were afraid of staining their clothes while menstruating. Coming to the next chart, to the next slide, that is, furthermore, 63% are not comfortable using sanitary pads in the public places. When asked if they feel comfortable, if they feel comfortable requesting menstrual products from school or places of worship, that is of 84% said no, they are not comfortable. Another challenge we found is that 53% of the respondents cannot afford menstrual product, and almost all of them, that is of 93%, are interested in discussing menstruation openly, but they feel scared to discuss it openly with others. So I'll hand over my presentation to Vicky John Lamary.
Thank you, Dafi, for that. Coming to the finding of this study, based on the result of our study, we find that our findings are in agreement with or align with some of the studies conducted by various researchers. The results of one study suggest that 68% of girls were unaware of the fact that they were menstruating before the first period. It was also reported in one study that 69% of the girls felt scared during the first menstrual period, indicating the effect this experience has on the emotional toll of our girls. As a result of societal taboos, many girls have difficulty discussing about menstruation despite being interested in discussing menstruation openly. 93% of respondents found it embarrassing to do so. According to a recent study published by UN Women in 2024, 66% of girls do not have access to menstrual products, which is also reflected in the study that we've conducted, where 53% says that they cannot afford menstrual products. The result of this study demonstrates that menstruation remains a taboo topic for many girls, resulting in them feeling fearful when they experience a first period. There is a persistent social taboo concerning discussing menstruation with male family members or male friends, with about 76% of our respondents feeling uncomfortable about doing so. Furthermore, socioeconomic plays a significant role in menstrual hygiene practices, with 76% of our respondents citing issues of affordability for menstrual products. To conclude, to conclude, the study found that there are substantial gaps in menstrual education and access to hygiene products. To empower young girls and encourage open dialogue about menstruation, comprehensive menstrual health education programs are essential, as suggested by majority of the respondents in this study express the need of more awareness regarding menstruation. For this, we can also collaborate with adolescent-friendly health clinic to raise an awareness program on such topic. These programs also will help debunk myths, provide accurate information, and create safe spaces for discussion. And implementing such initiatives in schools and communities, especially in Meghalaya, is crucial to addressing adolescent menstruation experiences and challenges effectively. Thank you. Now it has come to an end of our presentation.
Okay, thank you, all four of you. It was a very good collaboration with all four of you. Just coming to the presentation directly, I'm just curious and just want to ask you, like, since you mentioned that you have done purposive sampling, what was the criteria that you had made to, include the individuals in your sample? So one is that, and the other part, it's again from my curiosity, since I'm not aware about Meghalaya. Is there anything special, like any prevalent cultural beliefs and practices regarding menstruation in Meghalaya specifically you want to mention, which you came across? Just the two things. It's just from my curiosity. So first one is regarding the sampling, and the second one is just the common beliefs, if you have anything, something which is very different than our culture, common ones. Shoma, you want to add something? It was a very good collaboration. We had a very good survey report, I guess.
It is indeed a very good study that they have actually done. And apart from using already a structured questionnaire, they just like framed open-ended questions, I think, which leads to more impactful study, both in the qualitative wise and quantitative wise. So it was nice, but I need to add some of the things. Like, if you are like taking my opinion, and if you want to wish for like go for a further study, I would rather recommend some of the questions you have asked, like you all have framed, like the second one, which is like do they feel ashamed about it? See, like with the teenagers or the adolescents, the population that you have taken from class 8 to 10, so they are very much self-conscious. So what are the the domains of which make them self-conscious? If they are ashamed of it, then why? So you should delve into a little depth into that study, as well as it would have been really nice if you had put like conduct some focus group discussion among some teenager group, with facilitator being as moderator from that group also, In that way, if you can like make a compact study of a qualitative theme analysis as well with this quantitative part, it would have been really nice. That is my suggestions. And yes, and what ma'am was asking, please try to give an answer to that, and we'll wrap up after that.
Can you repeat the question again, ma'am? Because the network here is not very good.
The sampling criteria, like
Yes.
the purpose of using sample, like why did you choose a particular that age group? What was the reason behind it? If I'm not wrong, ma'am.
Actually, we choose only the girls from class 8 to class 10, only those who had their periods.
Because they've recently, most of the girls that we conduct this, that who act as our respondents, most of them have recently got their periods, so that's the reason we choose them specifically.
Okay, so what was the criteria? Like these people, as is it just the age group?
Yes, based on each group from adolescent, like from 10 to 19.
Okay. All right. And anything you have observed since you are there in Meghalaya? So I'm not aware of Meghalaya's culture and the practices and all. Like anything you want to mention? Anything, any special cultural belief in regard to Meghalaya's? You are talking about the menstrual hygiene. So anything you want to mention here? You found while you were conducting your study?
Mostly, ma'am, here we do believe that while having a periods, we're not allowed to take bath and we're not allowed to eat lemon and we are not allowed to eat like junk foods.
And and most respondents did say that they were not able to share this with their male friends.
Yes,
So
on context of that one, I just wish to like one thing. If you are interested really in this field, you can just try look into Nepal culture of Chaupadi. It is very, very, very famous and very impactful since very beginning of 1000 BC. I mean, from that time, this culture existed that is called as Chaupadi. That is a separate house in each Nepal, eastern region of Nepal. Most of the villages, they have a separate house for the girls and all the women who are menstruating. They treat some of the villages, they treat the girls like, kind of a farm animals and not allowing a girl into the house, and they have to stay in that particular Chaupadi house. Just look into this phenomena. You will find many interesting stories.
Yes, ma'am, we'll do that. Thank you, ma'am.
Okay.
I think with this, we can move to the second presentation. If we have the first person, Vitika, ready. Dr.
Thank you so much, ma'am.
Thank you so
Thank
much.
you, ma'am. Thank you, ma'am.
Yes, ma'am, I'm here, but I'm not able to share my screen. That's the main problem I'm facing.
Dr. Soma, Dr.
I don't know
Arunima,
what
please
is happening.
call Dr. Sagarika. Meenakshi is not there, so just jump to
Yes,
Dr. Sagarika Saha.
Sure.
Can I start?
Yes,
Yes,
Dr.
yes,
Saha.
yes, ma'am, please.
First of all, thanks to the organizer and thanks to the my most favorite chairpersons. I'm very happy and delighted to get you people in this forum. And thank you for the organizer to select my paper also. First of all, I want to introduce my paper that this is a working paper associated with some of my students who belong to Meghalaya. So I'm sharing the screen. It is visible?
Yes, ma'am.
Visible.
It is
Yes.
Yes,
visible.
yes, yes. Okay. So this is a practice-based study on the problem of teenage pregnancy in the Garo community residing in a particular village. The village is associated 4 villages. It is called Rajsingla village under the Kharkuta block of North Garo Hills in Meghalaya. So, some of the statement of the problem that we have recognized in working in this area, that the teenage pregnancy is a very serious problem in the whole of the state of Meghalaya. Due to there are a lot of reasons behind that. So, and the severity is a kind of a trending. It can change from one place, one area to another, and then this is a kind of what I say, that this is a kind of lifestyle in the Garo community. It is seen in present scenario, not in the past. I cannot say that it is already prevalent in the past times, but after from 2011 and 12, some kind of studies related to Ceylon Times. There is a newspaper on Ceylon Times, and it gives the literature's reviews that from 2011-12 onwards and after the pandemic, these cases have raised so much. So there is the age group that we found in our study, that is from 13 to 19, and it is both dangerous in for the mother and the child, and there are a lot of health consequences. Actually, these consequences are prevalent in our own state also, in West Bengal, and also in other parts of India. But in that area, it is more dangerous because those areas are very, very remote, and there is no transportation and communication is very less related to the urban or the rural areas of other states. So we can compare it with the other states also. So these teenage pregnancy cases that we found in our study, it is mainly on the lower middle classes and also in the some of the upper middle class families. Some facts that we have calculated. We have taken some kind of literature reviews from 2018 onwards also, but there is a important literature I found out, that is in 2022, that gives us that adolescence is a positive stage of life, and in this is a stage where we have lot of possibilities and potentials of the young children or the teenagers, because it is calculated from 10 to 90, and it is for the positive disorientation, maybe the negative disorientation, or a positive orientation or discovery in this period. So as the fact that it is very important phase of life, and also for the health related, because in this period with the health structure also is associated, that what is a better health or a good, or how we can transmit it into a negative phase of life, because in this period our health condition, if deteriorated, it will suffer for the rest of the life. So another study I want to highlight, that NCPCR has taken from 15 to 16. After that, there are a lot of studies also, but it highlighted particularly 12 states, and in those 12 states, mostly we see that Goa, Mizoram, and Meghalaya is the pertinent states where we can found that the teenage pregnancy cases are high, and it may be married or unmarried or means live in relationship. The specific area, it is Simla village near, it is in Assam border, and it is belong to Garo community of people, and basically Christian community. So in this community, first of all, I can emphasize on that there is a tradition of a matrilineal culture, and in this, this is a factor where after the engagement of the bride and the groom, the boy have to go to the wife's house. So this is a kind of a adopted generation-wise importance. It is not a thing that it is a presently they are sharing or they are doing this. This is generation-wise they're practicing. But what we have found in our study, that in the study area, these things are changing. How they are changing? That nowadays boys are engaging in different kind of jobs. Boys have the some kind of responsibility bearing. They have to bear some responsibility related to education, and also for the siblings and their parents. So this trend is somehow changing, but maybe in a slow process. So these are some research methodology particularly has been used in this study, that is exploratory study, but we have focused on some kind of social work methods, that case work and group work and community organization with different kinds of approaches also. Purposively that pregnant girls are selected, and in between when we started the study on 2022 and 23, we have got 30 teenage pregnant girls, and after that we have selected 10 from them for the in-depth studies. So we used some kind of tools, the listening, home visit, and we side by side have to interview with the parents and their partners also. Sometimes we have kind of community meeting with the health staff and the panchayat members. So some of the findings, I cannot conclude that these are the maximum findings. There are a lot of things, but I cannot conclude all these things in the presentation. So some of the specific findings which I found it that the causes. Why are the causes? What are the causes of the teenage pregnancy in this area? It is not only that Meghalaya, but it is trending in the northeast, all over the northeast. But specifically, there are some specific reasons for that. There is social and family dynamic problem is there. That economic problem is there in every, because there are a lot of people are there in the basically in the rural areas that we have pertinently taken for the rural areas. So economic problem is one. Another is this problem started from that thing, that because of the economic problem, the girls come out from their family and do their own work or do anything. That may be agriculture, that may be selling anything, that may be engagement in other work. So it gives an independent kind of life to them, and parents also neglected these things, that whatever the girls or whatever the women can do, they can get their independence and they can rule their life also, and fulfill their needs. So this is a kind of a cause we have found it. And there are another thing, the behavioral pattern. They are very free mixing, not like the many there is taboos, or the girls are actually very independent in the northeast. That I can from my own observation, I can say that their behavioral pattern is some kind of westernized, because they can mix with any people. They have an independent way of thought. So these are there. They don't have any taboos of mixing with boys or anything. So and another thing that they have many different partners. Means they have maximum male partners, and they doesn't stick to one or single. So this is another thing that gives this tendency of a teenage pregnancy. And another thing in the northeast, especially I have observed, and in Meghalaya also, that girls and boys both are taking alcohol and drugs. So these are the things. After that, they started falling in this problem. So then another thing, that in the school campus or in between the family, if we take the family as a therapy or as a family as a well-wishers and all, the knowledge of physical intimacy or the family planning methods or reproductive health is not discussed, or they are not of the knowledge. Even the mothers don't have the knowledge, adequate knowledge to give provide to their daughters. So these are the pertinent causes we have found that leads to teenage pregnancy. After that, we have done some interventions. First, I can clear out that there are government functionaries. They are working the health system, the school. There are a lot of consultancy services in Meghalaya. So they are working. We are not parallel to them, but we are under our program and we studied this. And some of my students are directly interacted with these programs. So we come up in some kind of intervention related to social work, that we provide educations through school or the health staff. Then we use that three-dimensional model also, the preventive care, curative care, and enabling dimensions also. Then problem driven interactive approach, PDIA. So these approaches are used to solve the exact problem on that situation. And after we have used some kind of counselors. There are a lot of counselors in those areas under the health and in the schools also. So you use them for counseling for providing reproductive health education also. Then the social workers there are engaged as an active social agent in the village level. But there is a negotiations and networking with the government functionaries at every level, because without the engagement of the local people, we cannot function because of the language barriers and other communication problems. So these are the things, and but the this working paper is on, and we are focusing on other different factors. Hope to get a positive output after some time or year. But the whole government and the private organizations actually hand in hand is working there for the development of the state and basically the reproductive health. So this is a final thing that actually I observed and have found out from our research. So thank you for that. If you add on some suggestions, and please, if you have any questions, please.
So, Dr. Shagarika, I just want to take this opportunity. Like, she is my fellow professor. Like, we work together. So, yeah, I do not have that much guts, maybe. But still, I just want, since it's just my curiosity, I do not have that exposure. Again, I'm telling you, like, especially for the Northeast zone, I know your thesis, like your title of the thesis also had an area, like, which was, I think, the Northeast India. So just one quick thing I just need to understand, like, what are the economic support? Is there an economic support system for these teenage mothers?
Economic support system means there is a livelihood program undergone through the government. Actually, I cannot incorporate all the factors in the presentation, so I've skipped off many things. But when we observed our study research, we have seen that in the panchayat level, just like in West Bengal also, but you can see that we cannot focus on that. But this is there is a problem of that political agitations, and you know that in Northeast, in all the 7 sisters in the Northeast, some or other scams, problems, hazards are ongoing in the all the years. So there is kind of some political agitations also, that whatever you want to do, you cannot do in a way that we can accumulate the economic thing. But government have tried founding some kind of SHGs through the livelihood program that is already in other states also. But some things are started, some schemes are already started, because beforehand I have actually worked in Northeast in Nagaland for 1 year. So I live there, and when I am there on
Dr.
20th,
Sagarika,
yeah.
sorry to jump in, but
Okay,
actually,
we need to wrap
sorry
up
to jump in between your answer.
No,
But
okay, sir.
actually, we are running
Just
because we have our AGPM to start on the time.
okay, sir.
So
Just
very sorry.
1 second, sir. Let me just finish it. So in that time, I noticed that whatever 2017-18, but these things are started about the livelihood of this and giving economic orientation to the women groups of the. Another thing that they have their inheritance of economic property. So they don't have actually the problem. But the problem is about the knowledge and the awareness. That is the thing. And the lifestyle. Lifestyle is totally different from the rest of India. It is another fact. Thank you, sir. Sorry for taking time.
Thank you. Thank you.
Thank
Sorry,
you so
sorry,
much.
I don't want to interrupt in between, but I have to. Sorry.
Yes,
I know it's an interesting topic. Yes,
thank you.
Shoma.
Thank you. Both the chairperson, thank you for.
Just one suggestion, ma'am. Just a quick suggestion. It was a very interesting topic. I just wanted to add two things. Like if you can include identification of teenage pregnancy, like this identification must have been through ASHA or Anganwadi workers through a proper channel or some resources, whatever resources you have used. If you can put that one. Another thing is the partner profile. Whatever the counterpart of that particular teenage pregnant women, whether they are married or not, or if they are married, if they are having any counter
Actually,
other
they are not
sex
married.
partner.
Yes, yes.
So that profile, I think if it was included. Another thing is how addiction plays in this role. Like there are different type of addiction,
Yes,
right?
yes.
So
Actually, it is in the total paper. Actually, okay. Thank you.
okay, ma'am. Sure. So
Yes,
I'm
yes.
sure you have collaborated all of these things. That is all from my side.
Actually, the students who are under me, they are actually Meghalaya and they are reside in that community only. So they are actually the main sources, and after that they have collaborated with the other functionaries. So
So
thank
it
you
will
for
be
the
really
suggestion.
interesting and nice study.
Yes, yes.
Yes. Okay. Thank you, ma'am.
Thank you.
I think we can move on to the next presenter.
Yeah, I think
Pinakashri Kalita.
this presentation is this. This is for Ritika, I guess, right?
Yes, ma'am.
Okay.
Yes, you can start.
You can start.
Okay.
Ritika,
Thank you, ma'am.
can I suggest to start from your objectives directly?
Yes, that will be really good from the methodology portion.
Okay. Very good afternoon to one and one present here. Sorry that I could not, play from my side because of, I think, network
okay.
issue.
It's okay.
Okay. Okay. So I just want to start with one or two sentence why I have chosen the Kamrup district of Assam as far as the topic is concerned, the impact of COVID-19 self-help group. So thing is that during the COVID-19, as we all know that all the people has been suffered like anything. So here, the Kamrup district occupies a predominant position in the starting of the SHG. So from the beginning, as we know, that in the Bangladesh, the Grameen Bank has been it was founded by the Professor Muhammad Yunus of Chittagong University in 1975. But in India, the self-help group's bank linkage program has been started in 1992. So here is a gap between from 1975 to 1992. But what happens after the 1992, the Kamrup district of Assam, occupies a major position to start a huge number of SHGs in the, out of that whole Northeast area. So they are continuously struggling their, kind of women illiteracy problem, the, distressing health, malnutrition. So despite of having this much of problem, the woman has started together, to do something for their economic upliftment. So as we know that during the COVID-19, most of the SHGs in India suffered due to lack of marketing and selling opportunities of their product. Beside that, poor supply of and unavailability of raw materials, that was the major hindrance they faced to continue their earnings. But there was some exception, that is, some SHGs were received order and support from the government to get the raw materials during the COVID-19 related products, like they used to build, make the mask, sanitizer kits, etc. from various government departments. So here in this paper, I would just like to discuss the process of manufacturing. Yes, ma'am.
No, please go ahead.
Is it okay, ma'am?
Yes,
okay, thank you. So yeah, so in this paper, I just want to discuss the process of manufacturing as well as the marketing of those products. That is products done by the or manufactured by the women SHGs in Kamrup district of Assam, who became involved in making COVID-19 related products and continued their earning successfully during that distress time. Though we know that there was a many, that was a situation of distressing. People were not allowed to go outside. They were not able to meet with the people. But as they got some kind of fund, raw materials from the government side, so they tried to sustain it. They continued their earnings successfully during that COVID time. So government like Assam State Rural Livelihood Mission, as we know that short from ASRLM, and various NGOs also conducted projects in many backward districts of Assam and observed that women are actively mobilized for the development of women self-help group and empowerment of rural women. So they, all the women are put together under some kind of SAGs, and they started working, and they got some kind of raw materials from the government, and they got huge orders also from the government side. So here in this study, I'd like to mention two objectives that has been framed to study the background of the members and products of women SAGs, and number two, to explore the products and the marketing process of women SAGs products during COVID-19. So for this study, I have chosen 20 women SAGs in purposely. So, and here also I have, kept some criteria, that is the inclusive criteria, where the women SAGs who received order and manufactured COVID-19 related products at Kamrup district of Assam during only lockdown period, that is 2020 and 2021. So here, the structure interview was scheduled made with the 30 major questions on the basis of objective frames as base tool of data collection. So this through that structure interview questionnaire, I have collected the data. So I just want to have a brief about the major findings. All the data, the tables, charts, and graphs are pasted in the down. So just now, I just want to share only the major findings here. Basically, the women SAGs, those who are they are basically from the economically poor family background before joining into the SAGs, and they do not have the regular income source. They were illiterate. Some of have passed their just basic education level. Age group comprised of 30 to 40 years, and mostly the SAGs are being formed in the 2008. 80% SAGs are formed in 2008, where I have taken under this inclusive criteria. Most of the SAGs are engaged in dairy and poultry farming and making other agro-based product, that is weaving also found among their manufacturer work. Next, a good number of members adopted new occupation after joining as SAGs. They started doing business and manufacturing products as per the local demands and requirement, as most of the products are being sold in the local shops, local market, or sometimes they try to sell their products in the melas or exhibition. So as per the requirement of the local needs and the people demanded, so they made their things likewise. Then in that SAG, they have their income has been improved, and they adopted a habit of saving also. It's common to like other studies, women SAGs members face little challenges to cope with the dual roles, as we know that they have to maintain their family, children also, and along with that, this SAGs concept also. So but maximum members has been expressed that most of them receive support from family members to continue their activities under this group, and even more during this challenging time in the lockdown, they have received training also from the government side. They have got the order from the government side to make the mask, to the hospital kit also. Next point is that most of their product were sold at the local markets by their own initiative, and sometimes obtaining support from the NGOs. Time to time with the support of
little bit, excuse me, can you be a little bit of quick, because I
Yeah,
think
sure.
Maybe the conclusion part, yeah.
Yes.
Yeah.
Yes.
Yeah, sure. Ma'am, just give me 2 minutes time. I'll be finishing
please
up.
make it
Yeah,
fast.
sure. Yeah. So as COVID-19 lockdown declared, like other SAGs, they also face problem like fetching new raw materials, selling of products, and manufacturing things. But however, they have received the support from the government side, so they were happy, and they faced very, they could manage the situation, and they could earn their livelihood from that challenging period also. So at present, the SAGs are earning, a good amount of money after the COVID area also. But in some SAGs, their income has been decreased if we try to compare that. And in post-COVID time also, the SAGs face challenges like get new materials, marketing sustainability of members, etc. But like other time also, they are trying to sell their products in the local melas or exhibition or just local markets. So in the down, some of the, sir, can you please show that this charts and graphs? There are some graphs and charts are also there. So you can see that reason for forming monthly income respondents. So that's the opportunities, things are there. So in the concluding discussion, I just want to say that though the COVID-19 imposed lockdown created income problems to the SHGs for the various reasons discussed above, but SAGs are formed to provide income opportunities as well, saving habit to lead a healthy and wealthy life to its member. So it can be concluded that SAG provides a good platform to the member for exchange of ideas and enhancing the decision-making capacity, and also it leads to the woman empowerment. That's all from my side. Thank you very much.
Thank you, Dr. Ritika. Since we are running out of time, one sentence I'll just add, like since you focused on COVID-19, if you can add a component on digital adaptation and online marketing, if there was any role, so that would have been a better something new we would have explored. So that's it, Dr.
Sure, ma'am.
Sharma.
I'll try to incorporate to some kind of other findings also if I happen to be in the field. So I will add this.
Thank you so
Thank
much.
you so much, ma'am.
Dr. Shaha, yes.
Yes, Pritika ma'am, it was really nice presentation, and you had made your point of including so many things at one time. I think we can move on to now the next presentation.
Thank you so much, ma'am.
Okay.
Thank you so much, Bhupendra sir, for just bear with me about the slide and all. Thank you so much.
Huwala Rao, the next.
Yes, sir. I'm ready.
Yes,
okay, you can
please.
start.
Just give me a second, yeah.
So the title is Empowerment of Women Through Leadership Among the College Students in Chennai City, right?
Yes, ma'am. That's it.
You can start.
Is it visible? Is the screen visible?
The screen not yet is rotating. Yes,
Yes, it is.
Oh, okay. Actually, the topic which I have given in the submissions of abstract is a little different. I have made some arrangements, so I hope you will accept that.
I'll just request you to kindly go to the objective first, what you tried to do, and with a very brief discussion, and then the conclusion.
Okay, good evening, the panelists. My name is Hovala Rao. I'll be presenting on the topic called Perceptions of Women Leadership Among the Female College Students in Chennai City. I have a co-presenter, Professor C. Devendaran, Department of Social Work in Mizoram University. I'm a PhD scholar. Let me go direct to the methodology. Okay. The studies was descriptive in objectives. All right, sorry. Here are three main objectives that I have given. The first is to find out the leadership opportunities provided to the female students, to know the social outlook towards the women leaders, and to know the awareness level and support available for the development of women leaders in the college. So the methodology that I use are, the study was descriptive in design, and primary data was collected using structures questionnaire and adopting the multi-stage random sampling. 50 women students were participated from the different departments of the college. The samples were purposefully collected from the Mark Gregorius College of Arts and Science, Chennai. So here I would like to include that the studies may not be, the findings may not be applicable to all the Chennai cities or to all the girls in Chennai cities. I have only taken the Mark Gregorius College. The findings and discussions, I'll go down here. So 80% of the respondents are from the undergraduate and 20% are from the postgraduate. Those are only female students. 70% of them have taken the leadership role in their school life, but 55% of the respondents have never taken leadership's role after joining the college, and 50% of them seek for leadership opportunities in the college. In terms of gender-based opportunities in leadership role, the study shows that 95% of the respondents were in the view for equal opportunities should be given to all the genders for the leadership role in the college, whereas 60% of them were neutral when asked about the gender preferences on leaders, indicating that they are comfortable to whichever genders they are. Though majority of them of the respondents receive encouragement from the teachers for leadership role, 15% of them say that they never receive encouragement from the teachers. So this studies is contrast to Colley and Copper 2008, where the professors do not always acknowledge or encourage leaders in the area of education. More than half of the respondents agree that teachers give more preferences to the male students for leadership role in the class, in which 37.5 of them say that teachers themselves they elect the class representative, and 37.5 of them they say that class representative is elected through the voting system. Societal perceptions and attitude towards women. Here, 97.5 and 70% of them agree that they receive constant encouragement from their family and friends respectively. And 95% of the respondents feel that the society is influential in developing women leaderships. But 68% of the respondents also agreed to the statement that the society prefer more male leaders. 50% have faced discriminations in their journey of leaderships. So these above findings corresponds to the UN Women 2023, as it says that societal stereotypes, cultural norms, and institutional biases continue to restrict women's access to leadership opportunities. And while assessing the awareness level and available supports mechanisms, 75% of them are unaware of the existence of women clubs or cells in their college. And 87.5 of the respondents have never participated in any clubs or cells that is available in the college. When it comes to providing leadership training program, 52.5 of says that their college never conducted leadership program for women, and 72.5 of the respondents says that they have desire to attend the programs if provided by the college. And 65% have never attended any external leadership program that is being provided outside the college, and 40% of them were willing to participate the external leadership program. 70% of them agree that the types of programs will help them improve their personality development. So this studies, this finding corresponds to Arun Jacob and Priul and Lee Code 2006 and 2017, as they said the positive influence on campus wide interactions on students' attitude, interests, and values on leaderships. Whereas it also acknowledged it will also acknowledge personal changes such as enhanced conflict resolutions and commitment to civic responsibilities. So in conclusions from the studies, we can see that women leadership among the college students in Chennai, especially in Mark Gregorius College, reveals significant insights into the barriers and opportunities within the educational environment. Despite significant societal and familial support, the persistence of gender biases and limited access to leadership training programs hampers women progress. Addressing these challenges require targeted educational interventions, awareness campaigns, and resilience building strategies to promote gender equality and inclusive leaderships. So, as a social worker, or as a social work practitioner, we can play a vital role in advocating for these changes, especially for helping the women to involve in leadership roles, ensuring a supportive environment that nurtures the leadership potential of young women, ultimately contributing to broader society's advancements. So that is all about my presentations. Here are some of the references, and thank you.
Okay, thank you, Hopala. It was a good presentation again, and the best is you completed within the stipulated time. So, regarding the methodology, just again, what I felt is since you mentioned about descriptive studies, I guess you could have had a hypothesis framed that would have been better supported the research design you had followed. That's one part. And if you had studied, maybe started with a case study, like if you could have given some examples of the female students who have been, benefited significantly from the leadership, experiences. Again, that should have been more interesting. But still, yes, it has new information and something we need to explore, I guess. Yes, Dr. Shaha, if you want to add something.
Yes, one just a small query. The place where you have collected your data, is this only women's college?
Not actually, it's not only the women college, but it's a co-education. Yeah, it's a co-education college.
Actually, one finding I found it contradictory. Okay, please, if you are willing to publish a paper and all, please look into that particular perspective. That is, you have mentioned that like a statistics demographic about those who have taken up leadership. And just after that, at some point you have mentioned majority of the the participants, they haven't responded, they haven't participated in any club activities and all those things. So how is that possible? Like, if a leader is not dynamic, or society, can not representing well, so actually this contradicts your study. Okay, so look into that. You can smartly look what can be the justification, or what are the reason behind it, because very interesting finding, I must say. So if you are incorporating into a paper, please talk to your supervisor. I'm sure he will guide you accordingly.
Sure, ma'am.
And it was a good study.
Thank you for your compliment, ma'am. I'll do the needful.
Okay, thank you. I think there are no more presentations, sir.
No more.
No, I think that's it. Okay, so I think we can just conclude. Yeah, we had a good number of, different from different dimensions, like with different types of respondents. Yes, it was quite interesting, especially we had few of them which are very, contemporary issues they had tried to focus on. So yeah, thanks ISPSW and Dr. Bhupender Singh for giving us the opportunity to chair this session. And I thank Shoma also and all the presentees and all the participants here. Thank you.
Thank you so much. Okay, sir, over to you.
Thank you, both the chairpersons, for sparing your time and giving very wonderful comments to all the sessions. Thank you, all the presentees, especially the presentation that have 4 presentees. It was a wonderful one. And that Dr. Sagarika Saha, yes, of course. I love that part and I wanted to hear, but time didn't allow me. So here I am stopping this session, and all those who are member of Indian Society of Professional Social Work, they are invited to join us on the AGBM. Link already has been shared with you. This meeting will end here and we will start at AGBM meeting. Thank you both the chairpersons, all the presentees and all the attendees as well. Thank you so much, one and all.
Thank you, sir.
Thank you. Now I'm ending this meeting.